All right, so I think I made myself. So thank you so much. Let's get started with the session. Hey, my name is Dr. Sharia. Going to start this session. I've been an MC tutor for a very long time, been 9 years. I've been through these MC paths, then was in Australia. I was in Sydney earlier, and then I think, here we go. Yeah, so I'm sorry about that actually. Yeah, in between it was mute actually. And we have two segments today, which we will cover today. One, this new changes in AMC, which is in 2026. And one more thing, there is a thing called this rheumatology. I mean, if you see our John Muttag organization, in the Sunday classes, usually we teach from the John Muttag. So in rheumatology segment, we'll go through this rheumatoid arthritis, SLE, then septic arthritis, osteoarthritis, along with the John Muttag ninth edition page numbers will be very, very important. Seropositive arthritis, seronegative arthritis, drug-induced arthritis versus, dermatomyositis, giant cell arteritis, and Behçet's, and some of the many other important aspects which is necessary for the exam. Very important question often doctor asks, doctor, those we see in the classes, usually this topic comes. Yes, 90% cases, this topics come, but MC also implicates sometimes new topics. So you need to, cover up these particular things. In the beginning, I'd like to check one more time if the sounds are loud and clear before later. I hope so we don't have to think about twice about this particular thing. Right, guys? Okay. So it's good, loud and clear. Let's get started. What are the new changes in AMC? Let's go. All right. All right. Now, what we'll cover today, of course, that's the second part, which is the rheumatology theory. And before that, we are covering certain things. So some of the exam updates, what's new here, what's some trendy topics in 2026, and preparation and the strategies. That is the reason most of the doctors came here. Some may not come for the course. Some also medical students are also coming, or senior doctors coming to know what are the new changes. Am I right? Please, that brings us to the point. Let us know in the comment section that from which city or country you are attending this particular session actually. Okay, so it will take just 30 seconds. Quickly just write it from this particular country you are attending this particular session. So that's wonderful to have all of you. Actually, I'd like to welcome if anyone just now joined. I'm from Dr. Sharian. I'm currently in Bangladesh, but I was in Sydney, Australia earlier. So thank you so much. Let's get started. And, I hope we have a great session. I believe we have a great session. All right. So some of the new changes and this and that. I'll also invite one of the doctor who is also currently in Australia. So he will be also, in between coming up. But in the beginning, I'd love to help you guys with some of the important things. Now, very, very important question that I was keep getting in my inbox is about this thing, which is about, doctor, is the passing mark thing has changed? That was the most asked questions actually. All right, so that was the most asked question, guys. We'll talk about the course study materials things in the like later half actually. Let's talk about this thing because some doctors might be busy practitioners, they want to go away earlier, so that's the thing. So is the passing mark, normally we must be, I think many of you know the how it is given 250. That's how the result came in AMC. Right. But honestly, the actual number of question is 150. Then how come it is like 500? So it's like a percentile system. Particular one question, how many people correcting that question, how many people make it wrong. Based on that one, every question is judged. So it's a complicated system. If you know cricket, there's a Duckworth-Lewis system, which is quite complicated. This is kind of like that actually. So it's more like a percentile system. So eventually they counted the barrier is actually 250. That's more like a percentile actually. So roughly, if I say that out of 150 question, you have to correct roughly 75, but originally it's always not 75. Sometimes it can be 72 can be your passing. It can be 77 your passing actually. It can be 80, questions can be your passing. If you know about, let's say, if you know about uh, PLAB exam. I mean, anyone have idea about PLAB exam? I'm sure you do. PLAB exam is conducted in 180 questions. Now, is the PLAB passing mark is fixed? I repeat my question. Is PLAB passing mark is fixed? Let's say like 120, you can think about a passing for PLAB part one. It is not actually. So some four times it is conducted plan. Some of the months it's like 120, some of the months is 125, some months is 116. So it varies actually. But they usually give the score out of that 150 question. All right. But in AMC, they go with the percentile. But the thing is, the original score, the passing can vary actually. You see the tip of the iceberg like 250 according to their standards. Now, what's the changes that has come? The passing score still reported 250, that is the out of the 500, which is roughly the 15%. But thing is, the internal benchmark thing has changed actually. Now, previously, how much probably you have to score like 77 or 78 or 80 or the level of the questions, the whole thing has updated with not lot of new sets of questions. Am I clear to some of the doctors already actually? So officially the scoring system doesn't change, but insider, like 150, your passing could be 75, could be 78, could be 79, and depends on the types of the questions, more clinical reasoning question, more population health question, more ethical question. So this particular thing has changed. I want a little response to see, if doctors are following in the comment section. Are we clear the step one thing, though, like officially not changed, but the benchmark has raised. The benchmark has raised actually. Okay, so that is the first thing. So, summary, long thing short, exam is more harder now. Okay, so exam is more harder now actually. Okay. Yeah, we'll post the record, no worries, but please try to attend because some segment may not be there, like new changes part may not be there. So theory part, definitely will post actually. Coming to the next segment of, if you already have seen that part, yes. So very important is if you see this part, think more like as an Australian intern actually. Let's see some differences. A lot of things in our country we think in our way as a doctor. So it's not like an Australian intern, but the level actually. We call HMO level one, level two, interns on HMO level one. So you have to be more like clinical oriented, which in our country some cases, we are sometimes thinking, okay, in our country, we saw professors doing this and not going through a lot of ethical things. But in those countries, now, one of the clear example, let me give you from the ethical background. You know, if there is a person needs to have a surgery, I repeat, a person needs to have a surgery, who takes the permission? Is it the professor in our country, or is it you or the nurse? So what do you think for our countries, like maybe most of us from India, Bangladesh, Pakistan, Nepal, Sri Lanka, nearby? So in that case, who usually takes the permission in our country? Is the professors, ask them, okay, in our country, the professors, the attending, they usually don't take the permission, honestly speaking. Most cases, actually. I mean, the permission, protocols, and this, that. But intern doctors, even some cases, nurses or seniors, they take the permission. Okay, surgery, and also do sign this, that. But in those countries, attending come personally, their team can be behind you, and then the attending is telling. So, are you giving consent for this surgery? I mean, this is the plus point, minus point. We are going for the surgery. I wish you all the best. Are you giving the commitment? Then you can tell, okay, you are the intern. Now you take the permission. Actually, that is how it is done. So you see a major differences. Okay, so that is how this changes. I'm just giving in one of the things, which is the ethical one, but there's a lot of medicine related, things are there actually. Like a lot of time, we prescribe antibiotic why it's not necessary. In Australia, it's very different. There's a lot of protocol red flags for every single antibiotic given actually. Unless until the criteria match, then only you give the antibiotic. There's a lot of scores, protocols, based on that one, and they're very familiar in their med school about reading about the scores and all these things actually. Yes. Yeah, someone said it's, no one actually takes permission in our country. But anyways, there's a consent form always been signed actually, but no one really comes actually. Yes, great. All right, we can make jokes of a lot of things. Okay, significant update. Yeah. So I was talking about clinical reasoning that I give an example of one of the clinical virginity. And one of the thing, if you see the last page, this kind of question we have seen more, but we'll get to see even more. Like let's say what is the most appropriate next step in the management actually, not like a statement type like true, which of the following is true, which is always false, which has been there asking very less, but few were there. But it means or brings us to the point they will be even asking more about the clinical vaguenity type questions. So now it will be things like fewer recall question. You don't expect, I just follow past paper and this, it is not going to work. Okay. And more, you have to be patient integrated cases will guide you more in coming days. We have been very updated. Do not to thinking style like more thinking as an Australian way based on the Australian guideline. The good thing that, we can guide you properly on these particular things actually. Great. That was the last kid. Forget about that. Talk about more on the ethics classes. Don't worry. Significant updates. We'll talk about enhancing clinical resonance. This is the one thing which I just know last page we have shown you. That was the last page on the clinical reasoning. How it probably looks like. Now, patient safety concern uh, in Australia, like the doctors are sued very easily. You do earn a lot money. So, example that brings us to the point that how much a doctor earns. If you're a junior doctor, you can earn like 10,000 Australian dollar actually. So it depends on your level. If you're joining level two, like all the doctors are joining level two. Interns is level one. Intern position are very short, so you will not probably get intern position if anyone don't have internship. So a lot of doctor who joined and asked us this particular question. You can ask this thing as separately. We're not going to discuss that part like how to join the internship position. But normally, as a doctor, we are joining the HMO level 2 or HMO level 3, depends on your experiences. All right. Now, the patient safety is very, very important. Now, in our country, we don't proceed in that way. Okay, see, I'm giving you this drug has this side effect, that side effect. Okay, this might carry some risk and this and that. You probably need to inform your partner. You probably need to inform your parents, this and that. Many times we don't do that. Example, let me give an example like cancer patient denial, often cancer patient often denial because you have to break the bad news. What happens in our country? Like normally the patient who is having cancer, let's say having cancer, normally sometimes they even don't know they have cancer. The patient's party son, they came and said, okay, please don't inform my um, parent that the person has cancer. Doctor agreed. Now, do you think is it right protocol for Australia? Do you think it is really a right protocol? Absolutely no. The patient will decide to disclose this thing with the family members actually. All right, so this is a wrong move, and a lot of time we agree with the patient part. Even okay, old patient, maybe he will feel bad, but it's a patient's right. That's called we patient's autonomy and this and that. All right, and also a lot of things when patient is going for surgery, this surgery carries this risk. C-section also carries a lot of risk. Does this thing also discussed in our country all the time? Like the C-section might carry this can lead to fibrosis, that can lead to intestinal obstruction later, this can lead to bleeding and death. No one talks about this thing. So the patient safety is very, very important. Medication, trial, surgery, whatever it is, actually, patient safety comes first. It's not only for the patient, also to safeguard yourself, actually, for Australia. I mean, because otherwise you will be in trouble, actually, for those particular matters. So, patient safety focus, I just give you a little example right now. That brings us to the third segment. Okay, what is indigenous health? Sometimes, there can be a different name. Aborigines, Torres Islander. Any idea what is that? Aborigine, indigenous tribe. They're local people who have been living in Australia before any other people came. Australia has a funny thing. You know how it has been discovered actually later on by civilized people. Like so, the UK, the ships they were everywhere, right? It came to also the this particular subcontinent. Also went to Australia at some point. Now they discovered Australia and they're very happy. That's why Australia and UK has very, you will see a lot of things in Australia inspired by the, like, in UK. Even they, yet till date, they give taxes to UK, as far as I know. Anyway, so thing is actually how it has been discovered and this and that, how it has been discovered. And initially they thought what to do with this big land, right? So they used to have a lot of, that time there was so many crimes. So what they used to do, they took all those prisoners and they used to set them in Australia. So understand one thing, the original Aussie people are kind of technically what? What do you think? The original, some of the Aussie people, like the white ones, are originally perhaps are the old prisoners, actually, technically. All right. So that's like a fun fact, actually, So they used to keep them because everywhere is island, right? So no one can go here and there. So that's the thing, actually. Very interesting fun fact. Lot of roads in Australia are made on those criminals' names. How? Now you can ask how. It's because, they used to keep them probably on that part, this part, and they find a way to come to near to the port. The ports were near to the Sydney, most cases actually. So somehow they used to find, then they ask them, how did you find that road? And they show it. Then they take them and then they hang them actually. But as a respect, even though take their life, but as a respect, they made that road on their name because they came through this particular road. So that is how, I mean, a lot of history were there. Some could be hypothesis as well. We heard this thing, but few names definitely on those criminals were there. Actually, that's a fun fact. Actually, anyways, so indigenous and community, they were even before they came. They used to be like some red Indian, Indonesian. They used to like very big size people. Actually, a little bit tan. They have their own doctors as well, by the way. Actually, after a lot of people, they only believe the indigenous doctors and this and that. So, indigenous health related and your practicing guidelines are also different. Let me tell you one thing, like the screening program, let's say ovarian cancer, breast cancer, cervical cancer, many other cancer screening program, also early age screening program, like started from 13 years of age group or maybe 40 years of age group. Many things are a bit different for the Aboriginal people. Is it clear, everyone? So whenever you are reading that, local guidelines, like, okay, John Murtax is this and that and this and that. So in that particular case, you need to double check the Aboriginal guidelines. So previously we used to check less in the classes. Now in this particular upcoming batches, I will teach this part separately as a subject because Aborigine, they are highlighting already. And a lot of doctors are totally not familiar what question is that coming. Okay, so you need to be more careful on that one actually. Like, so let's say we have been more trained on that one actually because we have been there. So we have been more trained on that particular part. Yeah. So yeah, guys. So I'll guide you more on that indigenous, like Aborigine, Torres Islanders, and their how to, you know, uh, do better for them as a doctor. So this particular thing is important. Okay, moving to the next slide. Yeah, so same thing, clinical reasoning. I mean, more clinical reasoning. There's a one group of doctor, whatever we give, teach in the class, they keep treating like this, So this kind of study will not work in coming days. Okay, what does it call? Memorizing. Some people say, like that. What do you say in your country? Rapta market, like or something. Yeah. So so anyhow, you study. I mean, it should not be. Yeah, rapta. Yeah. So yeah. So someone said more ratification, whatever. Anyways, pardon me if like language was not correct. But the thing is, I think we have seen this thing in the Three Idiots movie, actually, like Rapta Marke, that thing, I think probably he also wants to say at some point, actually. So you have to be realistic rather than memorization, actually. Okay. Practice and time management. A lot of doctors failed in exam every year, every month because of time management. So those we can help you with realistic exams, computer-based timer system. We can help you with that in future. Or even if you're not into your course, try to practice time more. Yeah, your probably studies top notch, but still you can fail because of only time management. That day is different. I'll give you an example. A lot of people practice really well. Let's say cricket. But day of the game, they got out. You can also name some, in our country, lot of, especially let's say I'm from Bangladesh, our cricket team is struggling. I found, I think, they got out and they said, I practiced so much, but the match day, they all got out, somehow. So that's the thing actually. So that's very important. The real practice matches are important actually. So here the practice exams are important actually. And deeply engage with indigenous health community already it's important. Yes. All right. Stay current. Yes, AMC has also website, so please double check like www.amc.org. That's very, very important. That is something very, very important for you. Actually, give you some important links I'll give you a lot of important links for our uh, like which should be very useful and reasonable for all of you actually. All right. Do you know the official MC website? I'm sure you do actually. Okay. So always double check, if there is a format changing, this and that changing. So you can also double check that actually. Let's not take much time on this slide. Actually, stronger areas to focus, of course, reasoning, evidence-based, see ethics and communication again and again they are telling emergency and patient safety. This again the same things, very, very important. Check RSCGP guidelines, you can check therapeutic guidelines actually, but it's more better to check initially RSCGP because therapeutic, say therapeutic nephrology, very big sometimes. If it's a tough topic, it's a very new topic which you don't know. All right, so that is how the thing is. Don't worry, we'll talk about the contents, material sharing, this, that. That's not the initial part of the lecture. We'll talk about those things later, actually. All right, definitely, my dear. Great. All right, great. Just familiar with this and that. All right. So it's also called CAT exam. Why CAT? Because computer adaptive things. Guys, if you, uh, do unusual things in the group, you may not stay in the lecture, like, I'm making a group, join in now, this and that. If you do, our team might remove you thinking as a bot, you know. So just be a little careful about unusual writing anything, while live class is ongoing, actually. Okay, so just be careful, like material change, this kind of term I just mentioned. Also, Zoom, lot of thing nowadays, Zoom has also some bot related support actually. Okay, so just be careful sharing because we have given some instructions to Zoom and our team. All right, so just keep going, guys. Now, 150 questions, 3 point. This is basic. A lot of people ask, is there negative marking? No. What is MCAT exam? Because it's computer adaptive now. Now, this brings us to the point. One thing, it's been an adaptive computerist test for very long time. All right. Why it's named computer? It's not a newly named. It's since even when we were also taking the exam that time. Any idea why it's called computer adaptive test? Now, let me ask you a cross question. Is the exam question is same for everyone in the test day? Interesting question. Is the test is same for everyone? No. Answer is no, because everyone has a computer, everyone has a central bank will ask you the question, not like plab exam, like everyone is sitting and then getting a question paper and solving it, marking it, not like that. Even on the same day, question paper from even the person next to you, giving an exam in a computer will have a different set of question. So just be aware. So it's adaptive. So and this adapt can sense love. It's more like a AI based actually, So it was there since very long, but now it's even more official actually. Great. Okay. And as you mentioned, passing is you have to get 250 out of 500, but the benchmark has raised a lot. In the beginning, we have mentioned that actually. Yes. All right. Okay. That's one of the thing. But before going to the books, let me take one, two questions from the doctors in this point. Now, there are a lot of individual subjects, right? Like which I think later on we can show you. There are a lot of individual subjects actually, like let's say medicine, surgery, gynae, ops, pediatrics, psychiatry, population health, this and that. All right. So when you get result, you often see there is a score and like bars like this, how much you got in medicine, how much you got in this and that. You did better on this. Like they will be giving you a like medicine, surgery, gynae, then yeah, pediatrics, and psychiatry, and ethics, and let's say population health, epidemiology, and this and that. All right. So, this is how, yeah. Now, the thing is, since the benchmark has raised, previously we used to see that almost everyone used to got a little less in this segment. What is that? The psychiatry and ethics, but yet they used to pass the exam. Yet they used to pass the exam. Right. Now the problem is higher likely they didn't make it as an official announcement, but seeing some of the students' result, I feel like every segment probably you need to do well from now on. Clear, everyone? Yeah. Yeah, benchmark thing is difficult to understand for, I mean, over the time, I mean, very loud and clear and simple, the exam has been more difficult with sets of question, with assessing the questions. All right. So thing is what I think, because they always don't like, they keep things quite hidden throughout actually. In Australia, it's always been like this. A lot of things they keep it a bit hidden. They will tell you things superficially. You need to, so, as I said previously, I've seen a lot of doctors which got maybe a little less mark in ethics and psychiatry, yet they used to pass. Now, and those used to fail, let's say they got less in ethics and probably less in medicine. Now, combination of two, they used to fail like previously. Now, I feel like I'm seeing some of the results, like individual one segment, they are getting less and they're failing. Understood? So they didn't make it official, but you have to be that careful. That means what? Every single segment you have to be more careful. As I said, it's not official, but seeing some of the results, I felt like that. Right? Clear, everyone? So every segment you have to do well. You don't have choice now. That's the only thing exam is more difficult actually. Right? Yes, that's I feel so. That's okay. You can pass it every segment. That means you're just taking good preparation in medicine, not in ethics. So that's the problem. A lot of books out there, some very old books like AMC Handbook, annotate book, there's another some official book, but a lot of official books apart from John Mutta, a lot of official books are very old books actually. All right, yeah, same. Bachelor is a part of the population. You also have to pass population health type of question, preventive medicine question, and the biostat altogether separately. All right, that's the thing. Now, speaking about the book things, I mean, when you guys with us, I mean, I'll provide you all these necessary books, as you can see. So don't worry. So about the book things, you don't have to worry, and we'll also give you so many SMA notes, which also has probably 100 more PDFs actually of different topics and system. Those will help you over the time actually. So, but I'm giving you an idea, basics about the books. One of the main book is always been that John Murtha. Currently, it's ongoing. Yes, the time we are taking this lecture, 2026 is ninth edition. It is ongoing. There's few more other official books, AMC Handbook. There's like this is another book MC annotated. Yeah. Capra series always has been quite a good, so Master the Board, you can see Davidson Medicine for Medicine. Yeah, good book. 100 Case is even though new semi book, but good for ethics. Yeah. Tizenda is a surgery book, always been recommended. There's a Linian Jones that is a gynae related book, and this red book sometimes you heard this is nothing but are CGP guidelines actually. All right, so there's certain type of books time to time in the courses will guide you more on those things actually. And here's like you can see these are PDFs, so definitely. Yes. Yeah, we do provide all these soft copies. So as the note things, coming to the MC clinical, since we are here for updates, so clinical also probably has some updates, this and that actually. Clinical, other than there's another called WBA. So you can see if you see the WBA, don't get uh, excited with this thing. Actually, it's not really reduced. It's just the online based one is actually turned off. So the online based its fees was different than the original. So don't get very excited on that one. Actually, the reality is exam fees is keep increasing. That's the reality actually. All right. So my dear Pesky, WBA, these things discussion over the time we'll discuss because individual classes sometimes we discuss things. Those are very big things to discuss about on a particular day. We're more here to discuss about the new changes, which I think I delivered already. And as I said, even in the MC clinical, new question settings are coming. Structurally, they didn't make major difference. Now, here is the thing: EPIC or verification, like you need to do the verification. If you have, now how many of you here have done epic verification? How many of you done a verification? It also has a new name, by the way, now. My Intel, right? It has a new name, My Intel. It has an app. With the app, you can do it. Keep forcing doing it. You will do it. You have your MBBS certificate and a recent passport ready. The rest thing, you just keep pressing with the next, 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 next. If you haven't done it, that's your first job to do. If you have aim for AMC, all right. Then you go through the MC part one, then the clinical exam, then there's a WBA. If you check my YouTube channel, my YouTube channel name is my name actually share it's your medical education. You'll find a whole like big video. Where I was talking to a WBA doctor already actually, so you can just go and subscribe and check that WBA video for now. In future, I'll guide you guys on the WBA more actually. So clinical exam and WBA both has a plus point of getting general registration, general registration, and eventually that AHPRA thing. That's the most important thing. General registration and the AHPRA, and followed by you can apply the peer and some of the other things actually. Peer and the other things. You can understand, dear doctors. I mean, in one class, we cannot go to individual things like AP, this, that. In future days, if necessary, I will take a session on that. All right. So as you all can see, and yeah, so after registration, that's your destination. All right. So here is the thing. As you all can see, a lot of things, medicine, surgery, gynae, ops, pediatrics, this, that. All right. So also chronic health management. These are also like preventive. These are also like a lot important nowadays, actually. All right. Like especially the screening part, actually. We updated our lectures a lot, especially screening, this and that. Yes, so these are the thing. Lot of not only this, there are like I can tell you at least 50 different guidelines in different time we use for different systems like RSCGP, RCH guideline, rank course, Medscape, Med bullets. I mean, I can keep telling actually, So it's I think class to class it will vary. Yeah. So I'll go for some important links and the resources. First of all, I'd like to show you those of you who are very new, I mean, if you see, this is official AMC website, how it looks like. Okay. So those of you are like medical students right now or a senior doctor, never knew about AMC, just had to know about this particular session. So if you just go to this website and open, I mean, I'm showing you a laptop view. So when you click that accredited and international medical graduate, so this is how it will look like. Here you will find AMC account. So if you want to make an AMC account, if you go and click this part, you will find that guidelines. So account and portfolio making, check med school eligibility. Now it's very important to check if your medical school is especially new, you need to double check, is it verified with MC? If your medical school is like seniors have done AMC or PLAB, then your medical school is already high likely verified actually. So primary source of verification. These particular initial parts are part of the verification and the guide you will find in the official website actually. All right. Okay, someone's one question, schedule November 20. Yes, you can take it, change it for free. If you take an exam, let's say on November, you can later change it for free. Yes. So for like 11 months, you can change actually. So November up to October, you can change any time, but it has to be at least 20 on day, roughly say 1 month prior. At least like if you are into the window of the exam, then it's locked. Okay. So you have to change roughly at least a month, specifically 21 or 22 days. Okay. So AMC part one, exam related all information, clinical related all information, exam center. Now you should check whichever is your close country. Like from Bangladesh, India is more closer country. So as also Thailand is closer country. So depends on your country. Check the AMC test centers actually. All right. So this is very, very important. MC certification is in another thing. After one and after MC2, you'll get certificates. Also after registration, you get certificates. This and that. Resources for international medical grade, you can also check. this particular one. So books, notes, this, that you have to study and you have to keep skilling, upskill yourself actually. All right. So I'm taking that screen just to share a few links for our dear doctors actually. Help you guys. Like, yeah. So just trying to, okay. So I was talking about AMC official website. All right. So we're talking about AMC official website first of all. And here is the link for AMC official website. I just give it in the comment section. Yeah, I just took out the main screen so that everyone can focus in the comment link. Yeah, now you can save it and save it in your notepad. Yes. All right. Those will be in our course, of course, WBA related we talk about later, so don't worry on that one. And WBA related, already there is a video that exists in our YouTube channel. Please go and find that YouTube channel, or if you don't know our YouTube channel, maybe I can share a link. Maybe you can subscribe that channel, maybe, and gradually later you can check about the WBA video, the clinical related video, and this and that. Actually, would be very, very helpful for you. I'm sharing that YouTube link right now, especially if anyone wants to know about WBA, or especially there's another video popular in that YouTube channel, what to do after MC part one. Generally, if you check that one, so guys, please click that one. Maybe you can subscribe, and later you can check that channel. So that's another important, I think, link, especially those ones just want to know. We keep posting so many recalls, even not necessarily has to be our students. So a lot of updated guidelines. So this is another instance, very large, just like almost 40,000 plus group. So this is, I mean, guys, try not to comment right now because I'm sharing some links actually. Okay. All right. So just maybe you can just send a request on that one. Yeah. Today's class related, just this update related file you will find there actually. Okay. After the session, I'll post it there actually. So this kind of post, I mean, initially seminar videos, this and that, their resources, any new recalls, this free files we post there actually. All right. And speaking about our pages and this and that, we do also have Facebook pages. If you want to check later, it's totally up to you. That's totally on you. If you just like it, I mean, in future, if you have a plan, yes, definitely, yeah, can help you with that one actually. All right. And last but not the least, I mean, where you will find everything. So if you check our official website, this is like SMA, our official website, a new one. Here you will find about, so someone asking how to subscribe, how to join, how to this and that. Of course, today's session is open. Our next session is also open for everyone. We'll do a recall session. Today is a theory session. So here is all the necessary informations are given. Actually, you will also find a class routine there at the same time. But class routine also we posted in our uh, particular group actually. But here you will also find everything actually. So I'll give you a minute before we switch over to our theory. After finishing the theory, if those want to stay to ask me a few questions, I'll happy to answer. We'll also make a, like a some kind of group things probably to help you answering few things. I think later even because after session, a lot of questions comes out in the mind. We definitely know, but we didn't want to get much late on that about the rheumatology. So about the rheumatology things, I think this is the YouTube channel, how it looks like, and definitely we are, yeah. So this is the John Muttak particularly. Okay, so I request you, first of all, I'll give you a 2-3 minutes break for just taking a glass of water and this and that, actually. Yes. Okay, good question before we left. Med school students, guys, you can read Kaplan at this point. John Muttak is too complicated for you. Let's say you are a fourth year, fifth year. You just double check the medicine books or fifth year books, medicine, surgery, kind of speeds. You don't need much anatomy, physiology, biochemistry. Those are not part of the syllabus. If you can go to my YouTube channel, there is a video on AMC syllabus. You will see mostly clinical subjects in AMC part one, actually. Not like USMLE one where anatomy, physiology, biochemistry are needed. I hope that helps actually. And if you can do one, two things like publications, make your CV better, yeah, it would be nice for you actually. Yes, and make sure you pass the exams, final professionals at shortest time actually. All right, guys, I want you to open 276 page in John Murtagh. So I'll give you guys 2-3 minutes break for refreshment and water. Yes, then definitely we'll start. Yes, thank you, my dear doctor. John Murtagh, a few things from the Davidson definitely, will yeah. We'll talk about those things more. Any of these question banks you can utilize. Both of them are great actually. Yes. We're ending that question section because we're going for a theoretical segment now. Otherwise, we'll be very late for the session, actually. Okay, you understand, guys? Later, if we have some time, we'll go for more discussion, or I'll open a channel so that you guys can ask me more questions. Okay, how about that one? Okay, great. Yeah, we already uploaded few links, I think. Maybe you can uh, check some of these links at your convenience will be more helpful. Yes. So I'm taking the screen. We're going for a short 2 minutes break. Yeah, you can stop comment for now so that others can copy these informations from the chat segment. And we'll start with the, yes, we'll start with the rheumatology. Just give me 2 minutes. I'll bring the books and all these things, necessary stuffs. You do the same if you bring your John Muttag, this, that, it'll be fine. Thank you. I'll see you guys in next 2-3 minutes. This is the end of the new segment things, and those wants to leave can leave the class. I mean, if you're just came for information, but those are into AMC. Now we'll have a session with them actually. All right, and you guys can leave me a message in my Facebook. That'll be fine, or maybe that's my WhatsApp. You can also keep it in future. You can also text me. Actually, not today. Today is too much. We are already bombarded with so many uh, texts. All right, so let's get going. So 2 minutes. 2 minutes to go. 2 minutes. We'll be back with the screen. Stay with me. All right, let's please open page number 276 from the John author. In a minute, we'll be back. Today's a Sunday. Thursday we'll be solving questions. Today we'll be solving the theory. Give us some time to understand the method and this and that. Yes, my dear doctors. Okay, dear doctors, confirm me one time if you can see the screen. I think we are going to start the rheumatology. Let's start a little bit in 2-3 minutes with the overview. Overview always helps. Okay, if you're looking for page, please open John Muktag Arthritis chapter, which is in the 276 page. John Muktag Arthritis chapter 276, which is ninth edition, certainly. Yes, eighth edition or seventh edition will not work here. Okay. So you need to, it's time for you to update actually. Okay, coming to this one, what we'll cover, guys, we have a YouTube channel, first of all, please double check that one. Today's lecture will be available because it's a trial version, so we'll post it in the YouTube channel, first of all. Coming to the next segments, and okay, we'll be talking about basics of rheumatology, clinical correlation, John Mortag, highlight some major diseases, and of course, now here's some page numbers, definitely. Here's some page numbers, definitely. If you, I mean, can write it down or it'll be available, the recording. These are the page numbers going to use. So arthritis as a part of rheumatoid arthritis and certain other arthritises, some summary charts, psoriatic, rheumatic, all these things are given. Yes. All right. So no worries on that one. Okay. And next thing we are going for is a like gouty arthritis, reactive arthritis in another page. I'll show you every single page we'll go through. So connective tissue disease, autoimmune. I'm just giving you idea. SLE, another one, antiphospholipid, systematic sclerosis, CRESS syndrome, which is related to again systematic sclerosis, Raynaud's temporal arteritis, and this and that. All right, great. Last few additional like pan, Behçet's, Wegener's, and finishing with osteoarthritis. We'll follow with a recall class on the Thursday actually. These are the topic. Always we keep eye because questions are mostly made from these particular topics. Okay, so here we go. Yeah. Guys, so before starting the things, checking one time if sounds are loud and clear, if that's okay with all of you, if sounds are loud and clear. Yes. Yes, loud and clear. I'm sure it's quite clear. We're quite professional, so I don't think so. It's anything to worry about. Yeah. Let me also take the whiteboard side by side. I want to write. Do you like whiteboard writing? Do you like whiteboard writing? Yeah. I think it's old school technique, so let's keep everything side by side. Yeah. So let's take a whiteboard in the side. Yeah, so that'll be really nice actually. And if you want to open in your John Mukta, if you have it, it's okay. Otherwise, just attend the class to get idea. I'll be posting the recording. You can see it later. So no need to worry, first of all. It's a rheumatology. Okay, so here we go, sharing the screen again. Okay, so that's the our rheumatology page. And we're going into John Muktag. John Muktag, no, 76, page number 76. I can turn off myself, so I think it would be more easy. Okay, so we're going with the very first one, the arthritis chapter, page number 276. Let's see what is coming out first. So first thing, what we like to start is some of the basics related to rheumatology, some of the basics related to rheumatology in the beginning, right? So what are some of the basics related to rheumatology? Let's get into the arthritis chapter. In arthritis chapter, you will get some information definitely, like about arthritis, it is a polyarthritis or a monoarthritis, this kind of information I mean to say. Okay, in the beginning, some questions are given. It's mostly given for the clinical, AMC clinical, so don't worry about that one. And here certain other points are given actually. Okay, so speaking about the basics, I'll draw for you. You can also check this thing, some cases from John Muttak, and few you can check from some cases from the uh, Davidson's first 10 page of the rheumatology. So here is a little reference, where I'm using some references, Davidson, uh, first 10 page for the basics, and uh, rheumatology, the clinical parts from the John Muttar, which is 276 page, arthritis and many other pages. Now, coming to this part basics, starting with that one, whenever someone is coming with arthritis and of course pain in the joint, it started with two things. So one is a monoarthritis, some cases, and one it's called polyarthritis. Poly and oligo, you can keep it in the same place. Mono means one particular joint. Now, can you give me some example of monoarthritis? Actually, I'm sure everyone knows. Actually, starting, let's say the first one, let me tell you the trauma. Trauma is the very first one. How many others you know? Let's check on all together. So, gout is very common, unilateral. It's very common unilateral. So traumatic, then gouty arthritis, right? Anything. If you say gout, then it's also can be, your pseudo gout, pseudo pseudo gout. Anything else? Very important. No one is telling that. Unilateral fever. Yes, septic arthritis. Well done. Things are not complete if you can't say things like that. All right. In case someone can't see, you can just log in and log out. The same goes with the sound because your network can be down. Anyways, trauma, gouty, pseudo, and septic arthritis. There can be many other. Even some cases, rheumatoid arthritis, other arthritis can initially start with mono. Now, coming to the poly, that means multiple joints involved actually. Can be symmetrical, but can be multiple. Always not can be like this one and this one, but like multiple joints. Now, coming to this one, starting with the very popular rheumatoid arthritis, osteoarthritis. These two are the in the top tier actually. Also, you can say ankylosing spondylosis, right? Ankylosing. So rheumatoid arthritis, oligoarthritis, like in this kind of thing, like dermatomyositis, polymyositis, polymyalgia rheumatica, many of those are. So the remaining thing, basically all the remaining things are, polyarthritis. So mono is basically few and poly, the rest. That is how you can remember. This brings us to the point. Did you realize sometimes the rheumatologist put certain thing in the investigation? A special thing is often they have seen CBC, with ESR is very common. And there's another thing called C-reactive protein. Have you seen things like, yes, what do you think? What do you think, guys? Yeah, in order to check the inflammatory markers like CBC, C-reactive protein. Now, let's talk about inflammatory diseases. Inflammatory diseases. Now, which one of them do you think inflammatory? That's why it will be helpful for you. Let's say, your rheumatoid arthritis, your gouty arthritis, your right, septic arthritis, definitely, definitely. Yeah, PMR, yeah, definitely. All those are going towards the inflammatory arthritis. Now, this brings us to the point which one of them probably has a normal C-reactive protein, which one of them is probably having normal, even though it's a popular one, but there can be normal, that is actually often we call non-inflammatory. So normal means what? It's non-inflammatory. That is a basic test actually. So non-inflammatory means the thing is coming osteoarthritis. I mean, very important, one of the things. Yeah, so this CBC ESR thing, this is the point, and this one is another point. Is it clear to everyone? Inflammatory arthritis, non-inflammatory arthritis, monoarthritis, polyarthritis. We're going through the basics now. Everyone clear? Yes. Then there can be a lot of other things. Do you have a flu? This, that. You can have a viral and this and that. We'll do more breakdown. But up to this, I hope everyone is clear. Up to this, everyone. Now, we like to do more tests. As a rheumatologist, you probably want to do even more tests. Like, let's say there are seromarkers like RA test, ANA test. Have you heard about this test? RA test is not only for rheumatoid arthritis, but it's kind of like the seropositive. Like rheumatoid arthritis, it can be positive, right? Some other disease also can be positive in case of RA. Am I right, guys? RA test, which is a blood test, can be positive not only rheumatoid arthritis but certain other conditions. Okay, so that goes with these seromarkers, seromarkers, RA. So either RA positive or either RA negative. Now, this brings us to a very important point. This brings us to a very important point. RA positive in which particular condition? At least you can name two, three. One of them is a rheumatoid arthritis RA factor positive, and there's another one called RA negative. Now, RA positive one, it can be rheumatoid arthritis. Can you tell me a few more others? Even in SLE, interesting thing. Even in SLE, yeah. So certain other conditions too, actually. Systematic sclerosis cases also, right? Sjogren's as well as Sjogren's. Yes, well done. So certain cases, seropositive it can be. Seronegative, on the other hand, is basically, four conditions. Four condition where the seronegative. We remember it as a RAPE, that particular word. What are those? Reiters, ankylosing spondylitis, psoriatic, and there's another one called enteropathic associated with the idea, blah, blah. It never comes in exam. But raters, ankylosing, psoriatic, sometimes we have seen tested. Especially ankylosing is out of them, is most popular. Other than the rheumatoid arthritis, then SLE, then, gouty, osteoarthritis, this ankylosing is very popular. We'll talk about them actually. We're still into the basic guys actually. So are we clear? Poly, mono, inflammatory, non-inflammatory, seropositive, seronegative. Clear, everyone? We're getting into deep down now, actually. So this is another particular sero markers. Now, more things. That is the radiological test. Radiological. What does it mean? More tests coming up. More tests piling up. If you do, let's say someone is coming with a knee joint problem, maybe non-traumatic one. If it's there is a trauma, of course we do X-ray, knee dislocation, this, that, but it can be because of arthritic problem. Is it important to do an X-ray for like a basic knee joints and this and that, and then followed by this CT, MRI, this, that. So an X-ray it can be done, followed by based on the test, then more radiological things are needed actually. Okay. Now, can you name one and two, those of the radiological thing? I'm just taking out the screen just for a second to show you something. Just give me a second, dear doctors. I'll show you radiology. Is that okay to dear doctors? Yes. Okay. We do have note in the note section. So first of all, don't worry. It's already given in the note section. The radiology I'm going to show you. It's already given in our note section. Great. So as we all can see, this is that radiology. We will break down this radiology. We're talking that radiology is important basic test. Yes. So a old person is coming in or a middle-aged person is coming in after giving this inflammatory, non-inflammatory, taking few histories, then of course we get into a radiology test. Am I right? Yes. Now, here we go with the radiology. Can you make some differences? Yes. Elderly person, let's say someone says he's 60 years and telling, okay, I have pain here, there, especially my knee hurts too much. Maybe you find that person a little obese. Yes. And its CBC and C-reactive protein is you find quite a normal, so it looks like probably a non-inflammatory. Now you come to the non-inflammatory, what is being given? Are you expecting loss of joint space? Very much. Are you expecting there will be less synovial fluid? Yes, of course. That's why there is a lot of friction. There's a lot of pain. Special findings, you see, sclerotic findings, subchondral these are, but loss of joint space is very much visible in the X-ray. It means, and also there would be, less synovial fluid. Now, interesting one point. Did you see there are few over-the-counter tablets available? Not even in our country, even in Australia. When some people come, we order them. Please bring those tablets. What are those tablets? Actually, very popular. Actually, especially they increase the joint fluid, especially two things: chondroitin sulfate, glycosaminoglycan tablet. Have you seen these tablets? I'm sure you do. Glycosaminoglycan, chondroitin sulfate. These are some of the tablets. Immunogogus. Yeah, sometimes I spelling can be pronounced different. Yeah. So these are the glycosamino. Yes. So chondroitin sulfate, they increase the synovial and prevents a little bit more cushioning, like more cushions in the area. So this joint space reduction, sclerotic things, painful areas, it's more better. Original osteoarthritis can be even more dangerous. I mean, we'll talk about that one. At some point, you might need even injections and surgeries. Yeah, it can be that dangerous. Coming to the next point, after osteoarthritis, we're into diagnosis now. Rheumatoid arthritis cases. Now, in rheumatoid arthritis, middle-aged female person, most cases, are you expecting joint space reduced? And this is a yes. Now, what help us differentiating between these two? Both cases, joint space reduced. In this case, you will also find another thing, that is osteopenic change. I repeat, there will be another thing which will be a osteopathy. I'm talking about radiological background. History wise, you will find, there are like seven different thing in rheumatoid arthritis, right? There's a criteria. We are not there yet. But radiologically speaking, osteopenia. Yes, there will be swelling as well, and also osteopenic, and loss of joint space is the common thing. The last but not the least, gouty arthritis cases will do the same. But interestingly, this time joint space is normal. I repeat, the joint space is normal, but there will be some erosion actually. And there can be also swelling. So swelling can be present here, swelling can be present in this case as well, but here normal joint space, but some erosive changes. Are we clear with this X-ray, guys? I'm giving you a chance. And in this osteoarthritis cases, LOSS, loss, is the mnemonic to remember. Differentiated with rheumatoid arthritis by osteopenia, and differentiation with the gouty arthritis, joint space, actually. I hope that's clear to all of you. Let's come back to our original, which is the basics we're discussing. So the three very, very important. This is how, if you read, this will really help you in the main episode. Rheumatoid arthritis, osteoarthritis, and the gouty we just learned actually. This brings us to the last and the more interesting. So radiology includes not only X-ray, there can be more things like CT and MRI, especially soft tissue. We consider MRI, but those are more advanced tests. There's a more specific test we haven't talked about yet. What is that? It's a more specific test we're talking about actually. Like, let's say it's the inflammatory joint space. Do you want to do something? I give you a hint. No, I mean, there's specific seromarker, those specific you are talking, auto antibody, or more specific tests like, anti-DS DNA, which we'll talk about when we'll go through the SLE, anti-DS DNA. Then there will be like, yeah, anti-CCP antibody. Every single has a different test actually, which is quite a different, right? There's a actually antibody panel. We call it, all together we call it ENA panel actually. Some places we do panel test for the serology, but we're talking about a specific test, like we have to draw something which is actually synovial fluid analysis. Synovial fluid analysis. Is it important? Synovial fluid analysis. Will it give you more clear idea? Yes. So synovial fluid analysis will give you if it's a inflammatory arthritis, and if there is so many WBCs, it will give you idea. It will give you idea about gouty like crystals. It will give you also idea about if it is a simple viral. Viral one, everything normal. gouty, and also you see some of the, especially septic arthritis, so many polymorphs, this and that, especially septic. Then there's of course this rheumatoid arthritis and others actually. Okay, is it clear? I mean, these are some of the basic. Last but not the least, in this one, let's see what we have gone through. Yes, test, and there is a one thing. Yeah, one more thing in a different page, 206 page. Sorry about that. Normally 275, but 1 to 3. This is one good and bad thing in John Muttak. Different thing are given in different page because they discuss things as a uh, clinical problem actually. Now this serological thing is also important for it. Okay, everyone. This serological one is important for you. You see this, my dear doctors? This is a that kind of like a panel on all the sero antibodies. You have to memorize it, like ANA for SLE, anti-DS DNA, more specific for SLE. ANA can be positive in Sjogren's and some other condition, but anti-DNS DNA is very particular for SLE. There's some other things, anti-La and anti-Ro. They are common in Sjogren's syndrome. That is also tested in the exam very often. We'll show you that one. Then there is another thing. Then there is another thing called, as you all can see here, yeah, like anti-centromere, particularly for Grace syndrome. Anka, you have heard the name before, I'm sure, like C. Anka, P. Anka. C. Anka, particularly for Wegener's granulomatosis. Wegener's antiphospholipid antibody for antiphospholipid syndrome. All right. And another thing, which is not given here, you can write it down as an extra. We take it from the Davidson's medicine. This is my job to tell you, which is not also present in John Muttak. Like antihistone antibody. Have you heard about this name? Antihistone antibody, which is not given in John Muttak, but what is this thing is related to? So antihistone antibody, I repeat, antihistone antibody, this particular thing is for drug-induced SLE. Drug-induced SLE. What are those drugs? Any idea? Hydralazine, procainamide, isoniazid. We remember in that way, hips don't lie, very famous song by Shakira, but hydralazine, isoniazid, procainamide. Hydralazine, isoniazid, procainamide, HIP. Great. Okay. So everyone, are we clear about some of the basics related to this rheumatology? Are we clear about some of these basics related to rheumatology? Is that a good introduction, I think, about the pros and the cons about the rheumatology? Now we can get into the main stem diseases. Now we'll get into the main stem diseases. We'll start with the rheumatoid arthritis. Are you guys ready? After one, two disease, I think then I'll give you a more bigger break. You guys have been with me for a certain time. I know it's tough. Yes. So please open the this particular part, arthritis, and in the arthritis, some basics are given. Then comes the viral arthritis. Before going into the rheumatoid arthritis, after viral infection, very common in children, right, guys? Like children got flu and this and that. Children can talk about joint pain and this that symmetrical often actually. So viral arthritis, it's a possibility. We just have to be careful. In viral arthritis may not be rheumatic fever or anything else like that for the viral arthritis. Another term we want to highlight, like children developing arthritis, like is it a only viral arthritis or is it by any chance juvenile idiopathic arthritis, right? You see high intermittent fever and rash. So few more points particular for the juvenile idiopathic arthritis. Juvenile idiopathic arthritis. So you have to be careful in juvenile idiopathic arthritis. Which brings us to the another point about the kids cases. From early age, it's like you heard about Jones criteria. I'm sure everyone Jones criteria. Yes, often this particular after a sore throat, kid can develop rheumatic fever, which the main problem is not only the system, it can also affect the heart. What is the condition in the heart? It is called in rheumatic fever. Rheumatic fever, someone like by, let's say, by streptococcus, there is a sore throat and followed by heart is affected. Now, there can be murmur eventually in the if heart is affected, and that condition is called what? Yes, and that condition is called carditis. So, if carditis is present in rheumatic fever, listen carefully this part. If carditis is present in rheumatic fever, is it important to take prophylactic antibiotic for very long time? I repeat my things. Rheumatoid arthritis, carditis is dangerous. If carditis is present, is it important to take antibiotic for very long time, up to like 21 years? Yes, antibiotic indeed needed and need to take for very long time. Yes. This brings us to the point, diagnose two major on, I mean, one major, two minor, or two major. This is the very classic for rheumatoid arthritis, like Jones criteria, major criterias. You can see Korea, synonym Korea like this, as like the spring ball we do, that's how the Korea, carditis in the heart, arthritis, multiple, and this is a special one, erythema nodosum, erythema marginatum. Erythema marginatum, this one is particular for the rheumatic fever. Erythema nodosum one is also popular, can be present in many conditions, but for sarcoidosis, erythema. So please take a special note for from our side. Erythema nodosum is often given with the picture, with a sheen picture, often with the sarcoidosis. Erythema nodosum one often comes with the sarcoidosis. I mean, which I will teach you in the respiratory system, definitely as a restrictive lung diseases. Now, coming to next one is a major. These are major. This is minor. You can see after sore throat, of course, there will be fever. Then there will be, you do test, ears a little raised, and prolonged ECG. Prolonged ECG is another thing. Now, this brings us to the point. AIMS always loves to ask questions in this way. What is the initial next investigation? What is the best investigation? Okay, how to make a diagnosis? What is the best approach? Or they will ask you what is initial treatment, what is best treatment. This is the most possible way MC will ask you. The more tougher one, if they want to ask, what is the next important approach? Now, that can be an investigation or either that can be a treatment. If they ask about what is the next approach, that can be either an investigation or either a treatment. Okay, coming to that particular point, can we say in rheumatic fever cases, ESR or this thing is the initial test? Very popular in exam. Couple of time it is tested in AMC. Okay, so ESR or C-reactive protein. Another one, ASO titer. ASO titer, this another thing. Okay, so this is another way to confirm the particular condition. Are we clear, everyone? So one is the simple blood test, which is initial, and ASO titer or throat swab, this, that, those are the confirmatory condition. Am I right, guys? Yes. And if you go to the treatment part, you see, of course, conservative rest and this, that. Uh, So in that case, if carditis present, not only antibiotic but also rest at the same time, and benzathine penicillin, you see this penicillin thing, and if there is a fever and this and then, of course, supportive treatment as paracetamol and the rest of the things are mentioned. Yes. Someone was say what they if they ask about management mostly means that actually they mean, I mean, you see the stem first. Sometimes they might not give you the other things. So if they ask what is the best appropriate management in this case, it also can be approach, it also can be treatment at the same time. Most cases the management, it comes as a treatment. They usually ask for the treatment when they ask about the management. It depends on the question stem actually. You see sometimes there's nothing given on investigation, only treatment, treatment, treatment. So then it's always the treatment. And if they mix with the investigation and the treatment, and most cases they can ask for approach, and then most cases they can ask what is the next best management in this case. That also means approach in that case. I hope that's clear to our dear doctors. Okay. Is a special line to uh, start with and careful. Any arthritis with high fever, young or even children, presents with high fever, single joint pain, single joint pain, you know, suspected septic arthritis until proven otherwise. Did you get that line, guys? Again, I'm telling a person, young or child, whatever, single joint pain and the fever, it is suspected septic arthritis until like you can do the other test, but you have to keep it in mind. By any chance, it is septic arthritis. From septic arthritis can be an entry point, then the infection can come into blood, then go to the widespread to the body, even can be dangerous sepsis. Is it possible septic arthritis can be turning into sepsis? Yes, can be very dangerous. Simple UTI can be turning into sepsis. Yes, we have seen many cases in our life that, recurrent UTI, then this infection widespread it, antibiotic didn't work, DIC, patient gone. So even septic arthritis, yet careful because joint can be damaged or sepsis can happen. So this brings us to the point, especially in sepsis case, what is the next step? I repeat, sepsis case, what is the next step? Most cases they can be IV drug abusers. It's a possibility. So what we do as a test, like to rule out what microorganism is that, staph or strep or whatever. So we do, of course, like fluid aspiration, eventually joint fluid aspiration. And of course, since it's an infection, high dose of flucloxacillin IV is required. Now, MC would often ask you which one first. Interesting. MC will ask you which one is first, joint fluid aspiration first or fluke. So this kind of clinical vigility they will put you in situation. Okay, the final answer is aspiration. So you can write this line near your John note. That this is how you need to take small notes in our class. Aspiration first, then the antibiotic. It's not like that antibiotic you give the next day, just aspiration and immediately you give the antibiotic shots. Is it clear? Antibiotic over the antibiotic first. Second is, IV flu clot shot. I hope that's clear to the dear doctors. Okay. Next piling up is we're talking about this too, and in this one we are getting this osteoarthritis. Okay, osteoarthritis. Everyone heard about osteoarthritis. I think everyone's home there is probably like one osteoarthritis patient. Am I right, guys? In everyone's home there can be one or maybe two that osteoarthritis patient. Now this is already given in our SMA note. Yeah, if you check our note segment, you will definitely find it. If you check our note segment, definitely you will find it actually. Okay. So coming to this one, I'll give you demonstration by the end of the day. I mean, how to utilize the notes and this, that. It's already the end of the notes. For today, just check the session, how it goes for you. Starting with the clinical virginity, imagine it's a 60-year person, female person, high likely, a little obese, and the patient is coming to you and complaining, Doctor, I have so much pain in my knee joint. Right knee is hurting a lot. Then your next question, is it only the right knee that, or is there pain in the other joints? This is no, right knee is more, but I have also pain in the left knee, sometimes back pain. Am I talking about a very classic symptom? Yes, I'm talking about a very classic symptom, which is the osteoarthritis. It's kind of like every house there is a like osteoarthritis. Now the next question you ask, do you feel like when you move more, you feel more pain? And yes, doctor, you are right. Yeah. So this is one of the arthritis which worsen with use. So the day progresses, which gets bad. Whereas rheumatoid arthritis is opposite. Did you know this information, guys? I will teach you the rheumatoid arthritis after this, but did you know this information? As the day progresses, rheumatoid arthritis gets better. They have usually early morning shakiness. Yeah, that's the thing. So worsen with use, improves with the rest. Classic your osteoarthritis. Now, few things. Is there possibility of joint deformity? Now, this brings us to one of those basic thing, which I think I was supposed to tell in the basic. the deformities. So certain, a joint condition where you will find deformities. What are those conditions actually? Now I can say rheumatoid arthritis, swan neck deformity, buttonia deformity, this, that deformity. Even osteoarthritis also has deformity. Heberden, Bouchard deformity. Gout has deformity? Yes. Gout technically also has deformities actually. Okay, so you need to figure out which particular joint has deformities. So gout has tophi, so technically deformity, right? So these are few points which is related to the basic. Coming to this one, like Heberden is more distally, Heberden is more distally, whereas Bouchard more proximal. A little bit information, not so much important for AMC. Just if you can remember, it's okay. If you don't remember, it's also fine. Heberden is distally, Bouchard's is more proximally. Great. Patient feel a lot of pain and stiffness. This is special line. Good days, and doctor says, doctor, sometimes, give me good treatment this time. Sometimes things are good and again it's get bad. Right. So this is very common in osteoarthritis. Some good days and the bad days actually. This is how it is actually. Is it inflammatory? No. So this is one of the very popular non-inflammatory joint arthritis, which affects the hand joints, knee, hip, back. It's very common actually. Arthritic changes are very common. Do we remember the radiology after doing the simple blood test? Of course, we need to do the radiology is going to give us more information. We very shortly we have seen a radiology where there was reduced in the joint spaces and there was subchondral cyst and sclerosis was there. Am I right? Yes, you remember that actually. Now the next thing we are going to do is checking its more unique things. So radiology wise, this is the something, this is already given in the SMN notes, so you don't have to take notes. Where you need to take note, I will tell you. So, do you remember this radiology? Yes or no? The loss. It's a loss, of course. Reduce in the joint space, sclerosis, patient in pain. It's a condition, uh, okay, but normal ESR. ESR will be normal, but other inflammatory arthritis, CSR would be raise. All right, so this is important. Someone has osteoarthritis or rheumatoid arthritis. Will they have more chance of pseudo gout or normal person will have more chance of pseudo gout? This is a very popular exam oriented thing, guys. I'm telling you again, it's very popular exam oriented. Normal people have more chances of pseudo gout or defective joints like rheumatoid arthritis, osteoarthritis. So the defective joint actually has more chances of pseudo gout. Even though pseudo gout is over 50, but already something defective joint. This brings us to the point. So see the picture, they have pain, this, that, degenerative, osteoarthritis. Now coming to the treatment, this is taken from the authentic guidelines, the treatment. Is it true osteoarthritis initially we try with simple conservative? Yeah, I think you are just early age having osteoarthritis. You just take simple paracetamol, you do more mobilization, and also do a little bit exercise, try to reduce load. Is our initial treatment is conservative with osteoarthritis? Answer is a yes. Now, time progresses, pain increases, then is it true, we go through the NSAIDs? True, but we have to also be careful with the kidneys. Now, patient is keep complaining, and we also tell them like, okay, you can take this and that to help the patient. That example, glycosamine, chondroitin, that those over the counter they can take. But at some point, as the age progresses, these all will not work up to this. Then what you need? Injection. A lot of patient in your practice you will find they're telling doctor, I have so much pain. I took an injection in past. It was really working well for me, but uh, I haven't taken the injection. Can you help me with that one? I'm not sure you find this thing in your practice or not, but we get this thing so commonly in our practice actually. All right, so a corticosteroid intraarticular injection is some cases helpful actually for this patient. And last but not the least, some cases it can be so terrible, the life is so much miserable that you have to go through the replacement surgeries actually. Okay. There was a one question in AMC if issues with NSAIDs can be managed with the tramadol. So they will also put you in realistic situations like this. Okay, so they will put you in realistic situation. That is something we call clinical reasoning type of questions. So the NSAIDs you want to give, but the patient has problem with kidney, patient problem with allergies, this, that, then what to do? Give tramadol hydrochloride. Guys, so is osteoarthritis so far clear? Is osteoarthritis thing so far clear to us? Please comment in the comment section. We can go to the next segment, but I'll take you to the John Murtagh ride. Yes, it's a elderly person. Then I would say, big joints are involved, pain at the end of the day. Keywords, you should write it near to your John Murtagh. It will help you. It is a degenerative disease, so non-inflammatory disease, yes, sir, is normal. Non-inflammatory means, yes, sir, will be normal. And you see multiple joints and the big joints are involved. Worse at the end of the day. Restrictive movement, yeah, they cannot. So mobility exercise is important. That is one of the reason. Those people do exercise, they get osteoarthritis much less. If you don't do exercise, you will get osteoarthritis more early. Also depends on family history, backgrounds of this thing. X-ray findings, are we clear already? LOSS, right? Loss, already discussed. Uh, did we talk about the steps of management? This looks better, or do you think the one I show you looks more better? Yes, I think the one, I think, yeah, stepwise, it's more easy. But definitely double check the John Murtagh as well. It's already given in the assignment note, yes, stepwise. So you should also try to make things, a lot of things you will find in our note section, but you should also familiar with John Murtagh. It's just a little scattered because it's not designed for exam, but still, it's your job to study this book actually. Okay. Great. So we'll read the rheumatoid arthritis, then we'll get into the breaks actually. Okay, the next thing is piling up is rheumatoid arthritis. Can you tell me some information for the rheumatoid arthritis? Let's see how many points. So this is a teaching technique actually, or learning technique, I would say. Whenever a disease you see, how to remember more things so that it fits in your brain. You see that disease, you try to find out four important words for that disease to explain that disease. In this way, if you start your study, you remember things more faster. Now, tell me four important things for this particular rheumatoid arthritis. Tell me four important thing for this rheumatoid arthritis, guys. Write down in the comment section. First of all, can I say it's a okay, good one. Someone said it's you know, early morning stiffness and a day progresses, they feel better actually. Deformity, okay. But initially, when you asked to say, like, okay, symmetrical, now that's a good point. Deformity, that's a good point. Okay. What about the ESR? Normal ESR or increased ESR? Very important. Inflammatory marker. ESR raised is inflammatory arthritis. ESR would be raised, my dear. Okay. Is it degenerative? No, it's not degenerative. It's usually in the middle-aged female. It is more common. So it's a inflammatory one actually. Yes. So someone said this correct. Is it also autoimmune? Someone mentioned that one right now. Yes, it's an autoimmune one. Well done. Well done, my dear doctors. Are you expecting RA to be positive? RA, yes. So I want to confirm it more. Anti-CCP antibody. I have to do radiology. I'll see joint space reduced. I'll see some, uh, osteophytic changes at the same time. Osteopenia, sorry, osteopenic changes. Right. Let's get into this question. Let's solve a question. Okay. Even though next day we have questions and questions, but let's see this one. Let us see this one today. Okay. A 61 with this particular problem, hypertension, rheumatoid arthritis together, went to the GP, worsening of the right wrist. He diagnosed with rheumatoid arthritis for 8 years. Okay, so it's a known case. Both finger, knee has been affected for several years, but his pain has been worse than ever before, than baseline. He is taking few drugs. Methotrexate is a drug, disease-modifying anti-rheumatoid drugs. These are the vitals. You can see the vitals. On examination, tender this, that, and right wrist is more want to touch. Now, we have some points which the following is the appropriate course of management. This is how original question comes actually. Now, what do you think? What is the right one actually? Is it because this rheumatoid arthritis thing is not controlled and came back? So you want to start the increasing the DMARDs, or you want to start a course of steroid in this case, or you think to perform arthosynthesis? Um, yeah, but the final answer is actually perform arthosynthesis. Why arthosynthesis here? Okay, we think this can be septic arthritis. Interesting. How come? Septic arthritis. Now, again, same like the pseudo gout, is septic arthritis more common in normal joints, or septic arthritis more common is in already defective joint? This brings us to it. So, already defective joint, septic arthritis is more common. So, because one particular joint is involved here, one particular joint is involved, so it is more chances septic arthritis and he can have rheumatoid arthritis, but he can also have septic arthritis. Is it clear, my dear doctors? He's already known for rheumatoid arthritis, but now single joint involved, swelling, pain, all these things, of course, more chances of septic arthritis. And his immunity is like it's autoimmune, so his immunity is even more decreased than ever before. Am I right on that point? Yes. So this is higher chances, decreased immunity, single joint involvement, it is septic arthritis until proven otherwise. Okay, so septic arthritis following a, yeah. Someone asked why temperature. Yeah, because septic arthritis does have temperature high. That's the reason. Okay, coming to this one, what the following is the most clinical arthritis in, I mean, these are clinical usually finding for rheumatoid arthritis, that arthritis is the next most common is morning stiffness. All right. Yeah, I think it would be Celsius, you understand. Okay. Next is coming is which joint is more affected is a knee joint. Knee joint. Okay, let's focus, guys. Initial investigation RA test, then is a anti-CCP antibody for further confirmation. We already mentioned about initial treatment. Of course, rheumatoid arthritis. So we'll think more about starting with the NSAIDs actually. NSAIDs. Whereas osteoarthritis cases and ankylosing spondylitis cases, we think more about the initially paracetamol. Is it clear, guys? Important information that osteoarthritis cases and the ankylosing cases, initially we think more about the paracetamol, but in this case, we think more about NSAIDs. NSAIDs sometimes not enough. We need more something, which is the disease-modifying anti-rheumatoid drug, DMARDs. Interesting. There was a question line like this. Best treatment to prevent the progression of rheumatoid arthritis. This is how the line was given. So much long information, so long information, and they're asking later, which of the following treatment is will help prevent progression of rheumatoid arthritis? Many people answered steroid, which was the wrong answer. Actually, DMARDs like methotrexate, that is the treatment. That is the treatment for prevent the progression of rheumatoid arthritis. Is it clear, everyone? So this is how the question will come, more practical. Yes. Cause of death can be coronary problem. Of course, rheumatoid arthritis has a extra articular manifestations, among them cardiac things are also there. Uh, Methotrexate fails, what to do? Now, this is very popular. We all know about methotrexate, and there's a second set of question. What if methotrexate fail? There's like immune modulators, rituximab, and this and that. Rituximab and the other some of the drug actually. Huge chance that you are reading a major disease and pregnancy related question will be asked. So disease modifying anti-rheumatic drug, uh, which is safe during the pregnancy and to be avoided during the pregnancy. Here is your information. You'll find this SMA note in our note section. You can see like medicine, rheumatology, RA, PDF. You can find it very easily. We'll give you demonstration at the end how to find it. All right. Now, DMARD use sulfasalazine, hydralazine. Must be avoided methotrexate. Is methotrexate safe? Many times there's a question with methotrexate. Is it safe at all? Methotrexate in pregnancy? Not at all. Neural tube defect, they can cause it immediately, but so as many other disease modifying anti-rheumatoid drug. Whereas sulfasalazine, these are safe. Now, there's a twist in the exam, and they will tell you, like, male person who is going to start a family, and that male person also has rheumatoid arthritis and taking sulfasalazine. Now, question is it safe to go with sulfasalazine for a male person? No, because it will cause azoospermia. If you don't know, now you know. Sulfasalazine can cause in male azoospermia. So that is the reason when he's planning for a kid, should not continue sulfasalazine. He can continue something else. So this is the exam relevant question. This is the exam relevant question. Yes. Okay. All right. Now, a few more things that in the same note you will find uh, some cases rheumatoid arthritis someone is having, but you need to do a surgery. Is there anything special you can do? Yes, cervical X-ray you can do because of there is a subluxation. Some rheumatoid arthritis patient have in the neck subluxation. So when you try to do the neck extension while doing the anesthesiology procedure, there can be very dangerous thing can happen. So a cervical X-ray is very important to rule out subluxation before procedure. Yes, it's one-time tested topic. Rheumatoid arthritis, definitely we need to do synovial fluid analysis. Here are pictures of synovial fluid analysis pictures. You can clearly see in septic arthritis, the cell numbers are huge high than any other. Please confirm, is this clear? Septic arthritis, especially having a huge number of WBC or the polymorph than rheumatoid arthritis. Whereas normal osteoarthritis or viral, they have very less finding. Yes. This one's X-ray may not be given, but mostly this kind of question will come to the exam. Okay, information should be given. This one you will also find in our SMA note section, my dear. Okay. As they mentioned, NSAIDs are the initial, not the acetaminophen or paracetamol here. And when it is not controlled, definitely disease modifying anti-rheumatoid drug. Here's a picture again. You see the deformity, Z-shaped deformity, button-ear deformity, and here is your X-ray, which is already given. Yeah, that's quite a clear. All right, now let's get back to John Murtagh. At this point, again, few terms already mentioned: multi-system disease like not only articular, but extra-articular manifestation. If you open the Davidson, you will see a box, extra-articular manifestation. Age groups are often young, middle age, female often. Here's an interesting thing, which I think I should have also talked in the basic. If we rule out the sex ratio, in rheumatological things are more common in which particular sex? What do you think? So mostly female is more than the male. Most rheumatological conditions are in, I would say, in a female. Now, can you tell me a few male-oriented rheumatological conditions? More actually. I mean, anything can happen in anyone. Let's say, starting with gout is one of them, and ankylosing spondylitis is another one actually. There can be one, two, but these two are the major one actually. So the one is a gout, and one is that, yes, ankylosing one. So this is another part of the this basic actually. All right. Coming to John Murtagh. So again, as like the rheumatoid arthritis, compare contrast is very important, guys. As like rheumatoid arthritis, this is also bigger joint involved. This is a polyarthritis. So many things, and also we found deformity from the basic slide. Which of the following condition has deformity? Rheumatoid arthritis is one of them. Okay. So and age group is important, like young to middle age group. Deformity, yes, this that. Some cases, joint swelling, is it expected? We saw in the X-ray, yes, swelling is quite a possible here. Swelling is quite a possible. After rheumatoid arthritis, we'll go for break, as we mentioned, my dear. Okay. Yeah. Almost at the end of rheumatology. Then, of course, some of those tests like RA test, then if RA test positive, then anti-CCP antibody test, and the X-ray changes already mentioned actually. Some extra-articular feature of rheumatoid arthritis, you see, it can also affect the lung. It can also affect the spleen as well, known as Feltis syndrome, known as Kaplan syndrome. Okay, but it can also affect like the heart. That's why the cause of death can be, yeah, cardiac. All right. Here's some criteria for diagnosing of rheumatoid arthritis, including like morning stiffness, then few more rheumatoid factor positive, ESR rays. So these particular things are the criteria you can have a look actually. Treatment things have been already mentioned. That initially it is NSAIDs, and then coming is a disease modifying antidote. When we come back after the break, we'll go for a 10-minute break now. When we come back after the break, I will start with the disease modifying anti-rheumatic drug, and then we'll go through the remaining important, like coming up is a gout and the pseudo gout, ankylosing. It will be more smoother one are coming up actually. The smaller one are coming up after that. Okay, my dear doctor. So when we'll be back, yes. So I think best would be this is the page number 291. Yeah, it's the page number. And but I will show you from the this thing from the this particular picture. So those of you want to study in between the breaks, it's also okay. This is the picture of the Davidson's medicine. I like it more because all things are given in one table, which usually we prefer. So when we come back after the break, then I will start with this pharmacology thing, which is DMARDs. Yes. Clear everyone, this thing? All right. Great. So break time, 10 minutes. Yeah, we have been talking for very long. Yeah, I hope so. Yeah, you guys are enjoying. It's a little long because we have to add the new changes in MC. I think I will come with a more louder voice after the break. Yes. Great. All right. All right, everyone. When we'll come back after the break, I will show you the syllabus one more time. Okay, guys. So stay with us. Thank you so much. I'll see you guys shortly. We're going for a 10-minute break here. One more information, we will also upload the record. So, but still, those of you can please attend the class remaining. That's also okay. So, major, these are the topics we also covered. Also, I think the Aborigine, another lecture will, I mean, separate system will come up this time, even though we are covering. Yes. This one's related video also available in my YouTube. Thank you so much, guys. Break time started just Okay, everyone. So thank you so much. And we are starting in next 30 seconds. Everyone is well, I hope. And let's get started. Okay. So as you see, I mean, this is part of the medicine syllabus. Very important. But, as we said, everything is now equally important. Everything is equally important. Then comes the pediatrics after medicine. We are currently first 1 month or 1 month, 10 days, we'll go through the medicine, then the pediatrics. Even if you are not like doing course and just coming for idea, this is your good idea. Like, so say medicine is more bigger, pediatrics is also bigger, but we try to squeeze, but probably you have to give a little bit more emphasis to pediatrics because every single segment, if now trouble, you can get faint. Yeah, so this is another thing. Then the surgery is quite vast, so here we go. Then, of course, gynae and the OBS, gynecology and obstetrics syllabus, including CTGs, or the psychiatry syllabus, including pharmacologies, ethics syllabus, psychiatry ethics. And a few more things are quite exclusive things. And with ethics, probably we'll add a special, session on the screening. Screening, we also take classes, so don't worry, it will come eventually. Which also mentioned as a here, but we also like to take it as live, and probably we'll take something special as a population health, and at the same time, Aboriginal, so it'll be a new thing would be added, that Aboriginal thing by the end of this particular batch lecture. Actually, we have to set up that one. I mean, normally we time to time tell along with the other subjects, but I think now it's time that you need to read it as a separate subject, the only about the Aboriginal health. Okay, so we have to make separate, guidelines and the notes on that. Okay, are you guys ready? Coming to the disease modifying anti-rheumatic drugs, if I just want to remind you, we have gone through the basic, and then we have gone through the uh, arthritis chapter where we covered septic arthritis, some child-related arthritis, juvenile rheumatic fever, this, that, osteoarthritis we covered, rheumatoid arthritis we covered. Coming up, a few of the things as like uh, SLE, gouty arthritis, these are piling up shortly. Before going into that one, I mean, regarding all arthritic condition, in our all arthritic conditions, actually, let's see, the disease modifying anti-rheumatic drug at some point may be necessary, especially the chronic and the big diseases like this rheumatoid arthritis, this SLE and ankylosing, this DMRD is very important. So this brings us to the point, pharmacology related to rheumatoid arthritis. Oh, by the way, guys, pharmacology is something you need to also give a little bit more emphasis. So anyways, so this particular chart, like methotrexate, is like one of the very important but not safe during pregnancy, but yet it's one of the mostly used drug, methotrexate and sulfasalazine. These first two are the most used drug actually. So in both of these cases, they have an effect on the bone marrow. Okay, before going into that one universal thing about DMARD's drug, most of them can affect the liver. You heard that right? Most of them can affect the liver. Okay, so if drug is affecting the liver, it can be drug-induced hepatitis. Yeah, so that is one of the thing, right? Most of them, I said most of them can affect the liver, can lead to hepatitis. So one that is common for all. Now, the next thing is important. Uh, Many of them can have an effect on the bone marrow. You see thrombocytopenia, some of them has other condition like CBC. So another thing we can see, many of them have effect on the bone marrow because these are disease modifying, so they are very powerful and they have a lot effect on the bone marrow. So same as the anti-tubercular drug, they are also some cases very much hepatotoxic as well. So in this one is mostly affecting also the bone marrow at the same time. So you see CBC liver function, CBC liver function, these are quite a common actually. Methotrexate, on the other hand, very popular for MC to remember. It can affect the pregnancy neural tip defect. So important to remember these things. Sulfasalazine in case of male should not be used if planning for a family. Right, guys? Sulfasalazine is safe usually, but if male is consuming it, and planning for a family, then should stop it. Why? Because azoospermia, which is not written here, but it comes as a separate for male. Hydroxychloroquine, I mean, everything is same like as before, CBC and this, that, but visual acuity is another thing to remember for the hydroxychloroquine. Lefunamide, again, CBC liver function test, but it can raise the blood pressure. Penicillamine can affect the kidney, can affect the urine eventually. Cyclosporine can be nephrotoxic at the same time. Cyclosporine is another one that can be nephrotoxic, some cases hypertension. Right. So few information we just found regarding the disease modifying anti-rheumatic drug. Guys, have you read the DMARDs before? Please let me know in the comment section. Have you read about DMARDs in the MBBS level before? Uh, Let me know in the comment section. Okay, now let's get time to get back to John Mukta. Here's a little bit thing given, like it's little bit given in a little non-specific way. I feel like it's given in a little bit non-specific way. I feel like actually. Okay, so I think it's preferred to follow the Davidson, that particular chart, or our SMA note also has this particular. You can take a screenshot of this one, or you can also check it from the SMA note actually for the disease modifying anti-rheumatic drug. Is it clear, everyone? I'm giving 30 more seconds. You want to take a screenshot of this one, or you just read it one time. Okay, everyone, time for switching. Yes. So here they have written in quite a non-specific way, which I don't like. Here's a line. All practice should be aware of the increased risk of infection of some conditions like atypical pneumonia while taking DMAT. So this can be an extra line for you. This can be extra line for you. Monotherapy often with the methotrexate. Yes, is standard. Okay. I hope that is clear to all the dear doctors. Taken off the screen just to bring something else for you. Okay, let me show you something from the our SMA note, like so gout and the pseudo gout. Gout is something more common. Can we say in this way that it is more common in male? Yes. Whereas pseudo gout is more common in female. Pseudo gout is more common in case of defective joints. Pseudo gout is more common above 50. Most of these cases, like gout, pseudo gout, your initial treatment is NSAIDs, like indomethacin. Let's come to this point. Yes, so here you will find uric acid. Here you will find a crystal. So gout and pseudogout both are crystal deposition disease. Am I right, guys? Gout, pseudogout both are crystal deposition disease. So gout can affect the joints, can destroy the joints, erosion and deformity. Pseudogout also has similar kind of effect, whereas crystal deposition or calcium pyrophosphate more deposition in the joint spaces. Again, let me remind you, in pseudogout cases, it's more often elderly people. This brings us to a important point, which I'm writing in your chat box. Are you familiar with this term PLL? What is that? Polarized light microscopy. I repeat, polarized light microscopy. Now, according to MC handbook, this particular thing also given sometime in MC, PML finding. When we do the polarized light microscopy, we get to see this view. What is this view? Crystal, is it needle shape or is it rhomboid shape? There's another term I like to use. We call birefringence. In gout cases, negative birefringence. Pseudogout cases, positive birefringence. You really need to remember these two terms. Again, I'm telling you, gout case, needle shape, pseudogout, rhomboid shape, negative birefringence, positive birefringence. These exact lines are often given in the exam. Okay, so they will give you a 40-year person recently have a meal. After that he's having so much pain. When you do PML test, it is showing negative birefringence. Diagnosis, please. And the pain is in more in the grade 2. He says he never felt so much pain in his life. Never felt so much pain in his life. So it's a single joint, male person, large eating, binge eating. It can be alcohol, it can be a meal, and negative birefringence. It is going towards the gout. I'll tell you a similar another synonym, scenario in case of pseudogout. Now, a 52-year person, known case of osteoarthritis. Now the female develops pain in the right knee joint. Pain in the right knee joint, already having osteoarthritis. Okay. And when you do PML test, positive birefringence, your diagnosis, please. Your diagnosis would be, yes, pseudo gout. Is it clear, guys, how questions will be coming in the exam? They'll give you a scenario, they'll be giving you a lab finding. Scenario and a lab finding. Scenario and a lab finding expected. If they want to make it more tougher, they might cut off the lab finding. So only by the scenario you have to make a diagnosis in that case. Both cases treatment are NSAIDs. Now, little bit next step treatment. Okay, this is how the pain. Can you tell me some drug names for gout? Yes, one of course the most important for acute gout is a NSAIDs. Then colchicine. I'll take you to John Mutta to guide you more on the treatment part. So NSAIDs, like let's say indomethacin, colchicine. Can you also say for acute gout corticosteroid or steroid? Yes, because some cases NSAIDs are contraindicated. In that case, in an acute case, steroids. Now, for the chronic gout, a very popular treatment is haloperidol. Can you say like that? Yeah. So guys, let's come into this one. Allopurinol and febuxostat, both are xanthine oxidase derivatives. This is how it is mentioned. Coming to the gout, coming to the gout part, dear doctors. Again, as I mentioned, this is something you need to remember. 4 words, 4 important words, if you can tell about gout. Okay, young, middle age, yes. Grade 2, yes. Worst pain ever, yes. Crystal deposition disease, yes. It can increase after alcohol and binge eating, yes. A lot of, I think, 5 points I mentioned. It can cause joint deformity, yes. By producing tophi, yes. Lot of yes I found. So you see gout versus pseudo gout. Yeah. So this side is for gout. Calcium pyrophosphate, pseudo gout. More common in knee, wrist, elderly person. Gout, more common in grade 2 and more common in young person. There can be stages of gout. Now, a quick question, a practical approach. Practical approach is very important for AMC in recent time. You have hyperuricemia, uric acid level elevated. Does it confirm you have gout? Understand the point carefully. You have hyperuricemia. Is it always means you have gout? No. Even for a cancer chemotherapy treatment, your level can be increased. So you need more test and clinical information actually. Some cases, asymptomatic hyperuricemia can happen 10 times more common than a normal gout. A lot of people have hyperuricemia, but they don't have gout. They don't have joint issues and this, that actually, but it's just they have a hyperuricemia. Maybe someone is taking a lot alcohol, this, that, they can also have hyperuricemia. Quite possible. So there should be staging, and these things are also important. So more common in male, red, shiny, swollen, hot joint. So this is important. Great. So you can see predisposing. Did you know? I'm sure all of us know there's a huge list for gout patients. Am I right, guys? You cannot eat this. Patient will ask the doctor, then what I can eat? So tell the patient if you can eat almost everything, but in a limit, but few things like red meat, seafood, and certain drugs you should be very careful with actually. On the top, if the patient have kidney problem, they should be even more careful. Is it possible, guys? Gout in long term can cause kidney problem. True or false? Answer is true. It can cause problem in the kidneys in long term. So 75% cases, gouts are common in the grade 2. Some cases it can be on the ankles. It can also cause deformity. It can also cause needle. So this brings us to the point after doing the uric acid test, after doing the CBC test, after doing certain other things like X-ray, can we do the joint fluid aspiration test? Answer is yes. So technically, this joint fluid aspiration is like a confirmatory. But do we always do this joint fluid aspiration for gout, or is it more like a clinical diagnosis? This is also important thing that a lot of disease, as a good doctor, you can diagnose clinically. So most gout things we diagnose clinically. Hardly we send a uric acid for further being more sure. So here we go about the gout, and here are the treatments of the acute gout. It's mostly NSAIDs. So except for aspirin, like let's say indomethacin is popular. Another thing in the piling up is like the corticosteroid to remember. Another thing to remember is a colchicine. If you mark the colchicine, please also write near to the low dose colchicine. You heard that right? You try to give the low dose colchicine. Okay, great. Low dose colchicine and high dose colchicine. Low dose colchicine in most cases where there is clinical impairment. Let's say a condition where NSAIDs you can use, can't use. Steroid you also can't use. Let's say Cushing syndrome and this and that where probably you can't use corticosteroid. You have gastric ulcer, you can't use corticosteroids. Okay. In that case, can we use colchicine? Yes. Is it high dose? No. All right. So kidney impairment and gastric ulcer together. Okay. So you cannot use high dose colchicine. Then what to do? Low dose colchicine. Is it clear, everyone? So low dose colchicine can be a treatment in case of renal impairment. Okay, so if we go more like long time, of course, weight reduction is very, very important. Also, you can see preventive like allopurinol. Okay, so this is another important thing. Guys, here's a very important information. Can we use allopurinol? Let's say someone is having recurrent attack. Can you use allopurinol in that case? On the top of acute attack, never use allopurinol. On the top of acute attack, never use allopurinol. When you give allopurinol, the crystals are more broken down, then there will be more pain. Already because of got so much pain, now you're giving allopurinol on the top, more pain. So you have to wait some time and then give the allopurinol. Clear now? There is a protocol to give allopurinol. When acute phase subsided maybe 1 week, 2 week, then you go for the, yes. So frequent attack, so you can, yes. So after certain time, you can give that one. All right. So this is the treatment for the chronic gout, very popular. So you see, 6 to 8 weeks after the last acute attack. So did you get the guideline now? When to introduce the allopurinol? So it takes some time for the crystal to be cleared. Yes, roughly 6 weeks after the last attack. Okay. If you give allopurinol and if it is not working, can you increase the dose of the allopurinol? Answer is a yes. We can certainly increase the dose of the allopurinol. It is a tested topic in AMC. Please take a note. Patient again having attack in spite of having allopurinol. What to do next? Increase the dose of the allopurinol. See, there are exemption thing. I mean, you can find. See, I mean, let me tell you, trial is a trial things actually. So many trials, so many things. If you also find try to search like let's say Sharia is a gout patient, you can also find things like that. You know, that is how it will come up. But let's say your standard guideline, you can check 2 3 textbook, then you come to a final thing. So the guideline you're talking about is probably from the website. The guideline I'm talking about are from the textbook. Every textbook is made of at least hundreds of good guidelines. That's how the textbooks are made. So in terms of preference, this is a important thing. Sometimes you'll be confused solving an MC question. Then what to follow? Doctor, this guideline is showing this, but textbook is showing this. Tell me now which one to follow in that case. Final answer in that case to follow is the textbook one. Because textbook is made of so much guidelines. There are a lot of trial that this can be used in acute gout, this cannot be used in acute gout. So many trials, PubMed, Coaching, so many, you know, uh, trials you will find. So this is one of the thing doctors get so much confused over the time. It's under the trial as well, my dear. Like using and what I know as much as I have seen that allopurinol using in acute gout, that's mostly into the trial things actually. They're trying it to use it actually. But the irony is patient complains about the pain thing. So that is one of the reason actually they are not using it actually yet till date. This is a very common practice in not only in these countries, also in Australia. Okay, great. All right. So when it will be regularized in the practice, then you can probably change our guideline. Now coming to the next one after gout is a pseudo gout. Almost similar thing, but I already tell you about pseudo gout. Like a 50 plus female has a knee joint pain and positive birefringence. Okay. And there will be calcification of articular cartilage. When you do more X-rays and more radiologists, you'll find calcification in pseudogout. So please highlight this line. So you see old, you see female, if in previous joint problem. These are the three important lines. Pseudogout treatment is also NSAIDs. Clear everyone? Yes. You can write indomethacin. We are talking about the basics if anyone is joint late, basics about monoarthritis, polyarthritis, basics about inflammatory, non-inflammatory like osteoarthritis, basics about using serologies like a seropositive, you know, like a rheumatoid arthritis, SLE, Joker, seropositive, seronegative, four conditions, if you remember. Guys, there are four conditions I mentioned for seronegative. Here are the conditions RAPE, Reiter's, ankylosing psoriatic enteritis. Right? Now, coming to those particular areas, starting with, let's say, with Reiter's. Now, what about the Reiter's? What about it? There's a famous mnemonic for Reiter's. Before I bring it, can anyone tell me that? Yes, some of you are right. For Reiter's is one of the very popular would be, for Reiter's. First of all, it says seronegative. What is seronegative means? Rh negative of an young person. Okay. And the famous thing, can't see, can't pee, can't climb tree. What does it mean? Can't see, conjunctivitis, can't be urethritis, hereditary arthritis. Okay, so that's your famous raters. There can be little history of diarrhea, then they can get some, uh, microorganism affecting them. So there can be little history of like diarrhea or any sort of illness prior, actually. That's the classic raters, reactive arthritis or raters, whatever you say. Okay. So here is a line. Can't see, can't pee, can't climb a tree. Famous prior urethritis, conjunctivitis, arthritis. Some extra things there can be like balanitis or buccal findings. Things can be precipitated by, you see, diarrhea type of illness like salmonella, this, that. Some cases, young person with a steady history like chlamydia. So they all are interrelated with raters. I'm giving you 30 more seconds. Think about it, or maybe you can take a picture. That's all. Again, this is a seronegative arthritis. Coming to next one is a ankylosing spondylitis. Now, there's a mnemonic for that, ankylosing. Okay. Speaking about ankylosing spondylitis, can you tell me some mnemonic for ankylosing? Mnemonic for ankylosing spondylitis. There's a lot of A I'm looking for. Let's say A, A. Let's see how many A you can bring for me. Yeah, already A for ankylosing. Then yeah, axial bamboo spine. Okay, no problem. Sometimes we often use this word bamboo because AMC is trying to give us bamboo. Bamboo is a like some kind of word in our country in Bengali. When things are not going in right direction, often as bamboo. Okay, starting anterior uveitis. That's the eye. Okay, next aortitis in heart, coming from the top. Eye, heart, aortitis. Next, axial spine. So bamboo spine. Anything in the lung? Yes, don't miss the lung. Acute pulmonary fibrosis. Is it possible? Achilles tendonitis. Another thing. So you see, my dear, there's so many A's are here. And another thing you can make in your own way, association. What do you mean by this association? HLA. It's a part of the investigation B27 association for ankylosing. Also, a few more things. Polyarthritis. It's more common in men. It's more common in young. Am I right, guys? So let's go into the John Motta to see what's given here. So as you can see, main X-ray showing bamboo spine and that mnemonic 5 A's. Let me show you one more time this 5A. I hope you have taken down. Yeah, this. Okay. Yes, young adults. So often, yeah, another A, if you want to make acute back pain. Often they came with the back pain. It is true because bamboo spine is common. So morning stiffness, this and that. So here are a few points. Morning stiffness, this and that. These are few very, very important points. Yeah. No, this is one of the thing, maybe a part of our basic. Let me add that one. Initially, a lot of basic things we mentioned. Let's me try to add a important clinical basic with the word morning stiffness. Morning stiffness. Now, morning stiffness more than 1 hour. Okay, this is one thing. Morning stiffness like a 30-minute, morning stiffness like 5 minutes. Can you tell me what are those points for morning? So more than 1 hour, it's for the rheumatoid arthritis, more than like approximately like 30 minutes for ankylosing spondylitis. So there will be morning stiffness, and very short would be for the osteoarthritis. Some stiffness, osteoarthritis also felt in the morning. All right, my dear. So morning stiffness, more than 1 hour rheumatoid arthritis, more than 30-minute ankylosing, and just like a 5 minutes. So they will tell you this duration thing. These basics we have read earlier: mono, poly, single joint, multi, inflammatory, non-inflammatory, seromarker, like a this condition, and seronegative we are already going through. Then radiological differences we have seen, and special one is a screening is a synovial fluid analysis. And there's a special thing we're learning that ankylosing spondylitis. Ankylosing spondylitis we're going through and about to finish. A for anterior uveitis, A for aortitis in heart, top to bottom. Then there is a thing axial spine related like bamboo spine, acute pulmonary fibrosis, all A as a mnemonic, Achilles tendonitis, and associated with HLA-B27. Now I'm taking you to the part as a investigation related to ankylosing spondylitis. Can anyone tell me what are the investigation you want to do? Of course, one thing we knew that we can do CBC and we can do the X-ray. X-ray will show bamboo spine. That's initial. What's next? The next is a HLA-B27. Here is a thing like that comes as a next. So X-ray, then HLA-B27, finally MRI. You need to remember all of them. X-ray, HLA-B27, MRIs, and mnemonic are like a 6S. If anyone joined very late right now, I think we have 20-30 minutes left. Maybe it's better to see the recording later. I mean, respectfully. Yeah. We already talked about the seronegatives we are going through, RAPE, and like reactive, ankylosing reactive. Just now we finished already, can't see, can't pee, can't climb a tree. We already discussed that part. I mean, before the ankylosing, it's a seronegative arthritis with these particular things. Yeah. Last but not least is a psoriatic arthritis. Now, psoriasis is a skin disorder. Am I right? And psoriasis can also affect the distal interphalangeal joint, same as like the osteoarthritis. It also affects the big joints and also distal interphalangeal joints. Now, psoriatic have a skin problem, and at the same time, this thing, special screening about the X-ray. I mean, initially you do clinical, then you do the CBCs, and then you will go for a X-ray. Now, what you want to see in X-ray? I want to see the hand joints. Now, what you will find in hand joint? I'm expecting a special thing, which is known as, let me try to show you. If I see if I can show you or not. Yes. Now, if we do the X-ray of psoriatic arthritis, first of all, it's a seronegative again, along with ankylosing and reactive arthritis. RA test is negative means seronegative. Now, in this particular case, like when you do the X-ray, normally X-ray is not like this, but this one is showing more like a pencil and this is like a cup. So pencil in a cup appearance. This is one of the spatial finding. Psoriasis also has very classic extensor surfaces involved. Psoriatic arthritis, some cases eyes involved. Yes, some cases nails are involved, which often known as a onycholicense or pitting nails in psoriatic arthritis. So hand, this one, joints, skin, even eyes. Is it clear about the psoriatic arthritis, dear doctors? Psoriatic arthritis, is it clear? I'm sure indeed it is. Yeah, I'll need a response from you guys. And E, that is another non-specific, that is another one. That one is not needed. So that's in the seronegative arthritis. That's the end of the seronegative arthritis. So we have finished couple of, and now we are heading towards, yes, this thing, which is in the beginning we discussed about it, which is the antibody test, general antibody. It is important. Other than the RA and ANA, there are another set of panel test. Okay, another set of panel test that we also do for rheumatological condition. Like once you get to know that okay, the person is actually have something rheumatological, then we ordered some panel test. Now inside the panel test, so many these things are there actually. Okay, all right. Great. Now, coming to this particular point, is another big one, and I'm sure most of us are familiar with this thing. That is a systemic lupus erythematosus, SLE. Now, as we mentioned, it's important for brainstorming. Can you tell me four, interesting thing? Can you tell me four things for SLE which you want to add? I mean, for a brainstorming next time when you study in this way. So, what are the important four things you want to add as a single liners? Starting with autoimmune, no, not a malar rash. Malar rash is a different thing. I'm not asking about the clinical feature. I'm about the disease, not a clinical feature. It's an autoimmune condition. It is an arthritis condition. And there will be arthritis. Okay, rheumatological condition. Okay, you can say in that way, unique way. One of the unique feature is a butterfly dash, but you should tell more about that. This is a autoimmune disease in a young female, which is related to rheumatological condition, and it is more common in female, of course. Another thing you can add, yes, seropositive can be another thing. Well done, my dear. Another unique thing, patient comes and tell you young female hair loss, young female hair loss, young female tiredness. Looks like maybe thyroid condition. Often we do the thyroid test negative, but yet alopecia continues. Sensitivity to the sun continues, weakness continues. Okay, doctors are confused to figure out what. Okay, so then they do more tests, they figure out this is systemic lupus erythematosus. Another way it can come. The person comes, there was abortion case and multiple time abortion is happening, and of course, seeing the face, there is alopecia, this, that, and some rashes. Why I'm telling that, a patient of SLE is like more abortion cases. It is because SLE and antiphospholipid, there is some association. Am I right? Yes. Antiphospholipid and SLA association, antiphospholipid syndrome, whoever having it, more chances of abortion, more chances of even stroke. Am I right, guys? Another association. Antiphospholipid syndrome, more chances of abortion, more chances of even psychosis. Well done. Very next level thing, my dear. Yeah, good knowledge. Even psychosis. Well done. Even Cushing has also this more psychosis feature. Well done. Yeah. Now, with the SLE, there's a mnemonic, or you go to the Google, you find so many mnemonic like Yeah. So you can remember this thing in that way, uh, like rashes, going to sun becomes difficult. Then there will be kidney features actually. Now, SLE also has mild, moderate, severe. How we understand it is a severe SLE by checking the kidney. If kidney is affected, it's probably a severe one. Am I right, guys? If so, lupus, yeah, lupus nephritis. Have you heard about this lupus nephropathy or nephritis? Have you heard this thing? Very big clinical trial goes on that one. Yes, page number 206. Sorry about that. 206 number page. So you can write this thing if kidney features, then it is severe. Actually, your treatment guideline would be different. I'm going to tell you in next 2 minutes the what will be the treatment in that case. Then, as you said, the psychosis can happen. The neurological involvement is also there. Yes. So this neurological involvement and psychosis can be also there. Is it possible SLE also has hematological involvement? Yes, definitely. It also has hematological. If you have learned anywhere, pancytopenia, that term, which is common for leukemia and some other condition, is this a condition also related to pancytopenia? Means RBC less, WBC less, and also thrombocytes are less, right? So this is a condition related to pancytopenia. It also has a lot of immunological issues, like, so it brings us to the point, decreased immunity, so eventually antiphospholipid syndrome and this and that, and also a lot of serological tests would be positive, like RA would be positive. Also some of the other tests like anti-dsDNA would be positive, ANA, this particular things would be positive. Those are also part of the criteria. Okay, so same thing with the SLE, articular features and extra-articular features. When you read rheumatological disease, I mean rheumatoid arthritis, articular feature, extra-articular feature. Read in this way, it will be easy for you to remember. Quick question. Rheumatoid arthritis also has heart involvement. SLE, is it possible SLE has heart involvement? Yes. SLE can also have heart involvement. Cause of death is also can be heart-related issue. So you see, this brings us to, yeah, Liebman's sex endocarditis. Very well done. Very well done. Very advanced. There's a one thing called, yeah, maybe someone read the Golson pathology book, maybe. Very good knowledge, my dear. So Liebman's sex endocarditis is endocarditis. That's a chain connection with the SLE actually, and patient will be presented with murmur. Yes, endocarditis. I will teach in very details in the cardiology section. Okay. Initial test, ANA. Confirmatory test, yes, please. Confirmatory test, anti-dsDNA. Anti-dsDNA. Well done. Last but not the least, is there any possible drug-induced SLE? You give drugs like hydralazine, isoniazid, procainamide. Hydralazine, isoniazid, procainamide. Okay? And SLE-like features? Answer? Yes, antihistamine antibody. Antihistamine antibody. I was talking that I will tell you the difference. I mean, the mild, moderate, severe SLE. Mild SLE, NSAIDs, moderate SLE, hydralazine. You can also use methotrexate. Write it down, page number 207 page. NSAIDs, first line, when you diagnose, then step up, hydroxychloroquine, another alternative, methotrexate. Now, talking about the very serious one, very severe cases, of course, steroid. Steroid is actually for acute flare-up. But I'm talking about the more DMATs things. Yeah, so you see the DMATs things are given. And when we understand it is actually severe, please write it down. Renal involvement. Renal involvement. Okay, a quick thing. SLE prognosis, what you have seen in your practical experiences. It's good, stable, or often relapsing, you know, So it's not a good prognosis. Like the patient of SLE are never really happy with it, actually, because it keeps coming back. So you treat some time, then it keep coming back actually. So the relapsing thing is very common. So the patient complaint is usually not good with the SLA thing. Okay. Before leaving, SLA, how it's given in MC, often a young female, hair loss, sensitivity with the sun, and recently arthritis. When you do test, ANA is positive. That is how you will find the SLE. Okay, another question. A young female and you find a different finding, certain different finding like a sausage shaped finger and a thick skin, thick shiny skin, a sausage shaped finger with arthritis features. Any idea, any guesses in this female? What is the diagnosis? This is a condition. I repeat, this is a condition. Systematic sclerosis. Systematic sclerosis. All right. So finger discomfort, arthritis, even some cases, tight skin. CERD and tight skin. It is also some cases known, and they have two variety that's too much deep for some doctors. It has a diffuse variant and a local variant. So local variant is called Crest syndrome. Maybe Crest syndrome you heard that name or read somewhere as a short note in past. So they usually have these particular features, including esophageal, hand feature, hand color changes, exposure to cold, sclerodactyly, sausage hand, and blood, some of the things. So Crest syndrome in that case. Crest syndrome in that case. All right. Here's a special tip because practice tips are more important now for MC. Watch for scleroderma crisis. In that case, there can be even renal failure with hypertension. Very interesting. Yeah, someone said this line, morphia. Well done, my dear. Well done. Okay. Up to this, is it clear, guys? SLE, systematic sclerosis, and there will be another one, Sjogren's is coming up. But before Sjogren's, dermatomyositis, let's finish it actually. I'll write few things for you. I know it's a little long today because we have to involve what are the new changes in AMC in the beginning. If anyone joined late, you can see that lecture later on. This was, something we took the session earlier. AMC new changes and this and that. No worries. Okay, we're talking about a interesting thing, which is like three conditions together now we will learn. One, starting with dermatomyositis, also known as polymyositis. Then there is another one, polymyalgia, rheumatica. And last one is a drug-induced myositis. Example, statins, like use anti-lipid drug and these things. Okay. All of them has a common feature. MC is a proximal muscle myopathy. Proximal muscle myopathy. Now, what do you mean by that proximal? Like example, I try to do this act. I need to use my upper sets of muscle, the proximal muscle actually. Let's say I raise my hands. My proximal muscles are used actually. The very common thing, the patient notice. Let's say female, they notice is what it could be. One of the very common act would be the female comb their hair multiple times. It's very common in them. So that's also can be affected. Also, you wash clothes, as you put those cloth onto the hanger. Again, your upper shoulder girdle has to be used. So that particular function. So proximal muscle myopathy, this thing is a very common thing for all of them. So difficult to comb hair, difficult to button the upper thing, raise the hand above the head, all this becomes difficult. Okay, so this is the adult version, like number one, number two, number three. Okay, now how we can differentiate? One thing remember in MC, lab is always over the clinical feature. Even though we understood by clinical feature, but lab has always been a confirmatory. Now we do particular two tests, ESR and CK here. CK or CPK, whatever you remember. ESR, because dermatomyositis, itis, also known as polymyositis, same thing. ESR raised, CK also raised in this case. Next coming is polymyalgia, then rheumatica. In this case, a very elderly person, 50 years person complaining I may have shoulder in very different parts and also the same common problem, proximal muscle problem. In this case, only I will find ESR raised, but interestingly, what I found here right now is this CK is normal. Next one is a drug induced, and in this drug induced one, what I found is ESR is also normal and the CK is also normal because it's a drug induced, not a typical inflammatory one. So this brings us to the point that dermatomyositis, polymyositis are not inflammatory, so ESR CK raised. Polymyalgia rheumatica only ESR raised, and drug-induced myositis, both of them stay normal. With this note, there will be so many AMC questions, a 5-star, it will be tested again and again and again. Is it clear, my dear? I'll hold here 30 seconds if you want to finish writing. This is it. Proximal muscle myopathy. Then these three conditions, that is the adult version 3 condition. These are the findings. Everyone please need to confirm me in the comment section if it is clear. Only 2 doctor confirm, rest of them are sleeping, I guess. Okay, no problem. All right. See, it's very fun to stay and not doing anything in life. Remember that. It's very easy to stay lazy and not doing anything, you know? So, and there's a group, they keep trying and doing their best, even in a simple situation. And that makes the difference. All right. Never complain that, I mean, later in your life, if you didn't succeed, like, I wish I could have tried enough. Now, why you never tried that time, that simple time? It's a very deep word. Try to remember, and we are telling from our experiences. Okay, this one also has a child version, that proximal muscle myopathy. Anyone can tell, what is the child version proximal muscle myopathy is. Child is not going to take drugs, so that's out. But there is a special condition named as DMD, Duchenne muscular dystrophy. Have you ever heard about this condition where there is a special maneuver, Gower maneuver actually, right? So in that particular condition also your CK will be raised along with that. Yes, sir, and the CK thing will be raised actually. But for confirmation, how we confirm this condition? We confirm by muscle biopsy. Is a special thing. DMD, Gower sign, yes, sir, CK raised initially, confirmed by muscle biopsy. So same proximal muscle myopathy, child version, adult 3 condition, child. This one particular, this one thing is morning. I think in the beginning we have already mentioned about the website where you will find our class schedule actually. Otherwise, at the end, we will also give you the class schedule again. Okay, remind me at the end. We are in a flow now. Yes, definitely. Thanks, my dear. All right. Now, next one is a this is clear, guys. This thing I'm sure is clear. Poly and dermatomyositis, most common in female. Proximal muscle weakness. I'm just giving you all the bullet and necessary points. You see helitops rash, thickening skins, yeah, this, that. Okay. Now, there is a condition named Sjogren's syndrome where everything is dried up. It's like a dry land. Eyes are dried, oral cavity is dried, even skin is dry. Sjogren's syndrome. I have a very nice picture for that, for Sjogren's, if you just allow me. Guys, try to show sometimes cartoon nice pictures. Do you like those? Let me know. Yeah, anything that helps us memorizing is better. Okay. Before going to Jogrens, my dear doctors, again tell me four important things. Let's do a brainstorming. Four important things for the Jogrens. Autoimmune, well done. Autoimmune, serological test positive also. Which serology? Anti-La, anti-Do. There's two serologic positive, anti. So serology positive and autoimmune. It's a dry land, everything dried condition. It's a dried condition, autoimmune condition, where everything is dried. And it's a rheumatological disease at the same time. Okay, so see the eyes, mouth. So oral, can we expect oral um, hygiene would be affected? Can you say like that, oral hygiene, because your oral secretion is not enough? I mean, why we don't get always dental disease? Because it's moist. For them dried, so dental caries, dental this that would happen. Okay, so that's the Sjogren's syndrome. Sjogren's syndrome we're discussing 210 page. 210 is the page number. Sjogren's. So anti-La, anti-Ro. Yes, good information. Increased risk of lymphoma. Well done. So difficulty, dryness. These are mentioned. Anti-La, anti-Ro, autoantibody, test positive. Now, important question for exam: what is the initial test? What is the confirmatory test? These are actually two important things for the exam. Answer: of course, you can do blood test, but there is a thing called shimmer test. Shimmer test, what is that? You take a small litmus paper, you put into eye. Normally, the amount supposed to be wet. Now it will be very less. Okay, that's the thing. You can also do blood test like serology. So these two are the initial test. So shimmer test and the blood test are the initial test. Now, which one is the confirmatory test? That is not written here in John Moktak. That is, I will tell you. Yes. So confirmatory test would be, so confirmed by, okay, biopsy. Because your salivary gland would be affected. So salivary gland biopsy. The treatment is symptomatic for dry eye, dry mouth, and also for pain, and eventually autoimmune, so steroid. So treatment is mostly symptomatic. Am I right, guys? After making the diagnosis, the treatment is mostly symptomatic. And in advanced cases, you can use DMARDs to prevent the disease progression. I mentioned, remember the line for the rheumatology earlier? Which drug prevents disease progression? Disease modifying anti-rheumatic drug does the disease progression, halts the disease progression. Everyone clear about this? Everyone clear about this? Okay. Next thing which I'm going to show you. By the way, guys, vasculitis is not a part of this one. Vasculitis we focus more on in renal system, but if you want, you can read it in advance. In our note, it's also vasculitis notes are given. I'll show you something from the Raynaud's. Uh, Before I show you something, what do you mean by the Raynaud's? Extreme exposure to cold, what happens next? Extreme exposure to cold. Normally, we don't have that, but those are Raynaud's positive. They usually have some. So certainly, yes, there's a constriction and eventually starting to have some color changes. Reddish, whitish, there will be some color changes, right? That is the Raynaud's. Question is it so common for normal people? No. Unless extreme cold, someone went to Himalayas, yeah, and frostbite and those kind of situation, that is different. Okay. I like to tell you and show you how it's tested in exam because otherwise it's little difficult to understood. This is how the question is. 25-year female with Raynaud's phenomenon, means color changing in hands, in exposure to cold. Now, you have few findings, and this is happening for a certain time. Maybe the person is a long time patient for lung infection. ANA negative, ENA negative. Now, what can be the cause? This is how it was given, and it looks very confusing. Primary, then scleroderma, SLE, systematic sclerosis. This is how the question was given in AMC. So I brought that question so that you can see, what are the confusing points actually. This is the only question so far I found from the Raynaud's actually so far. Now, coming to this one, every single point, let us double check from this particular box. 25-year, it's less than 30-year. Then there's another thing. Is there any systematic disease? No, Raynaud's can be because of SLE, Raynaud's can be because of systematic sclerosis. In those cases, they have systematic disease mentioning in the question, nothing really mentioned. Only mention lung infection is not enough. So only Raynaud's, it's not going towards the secondary. Secondary Raynaud's means because of secondary disease SLE, secondary disease scleroderma. Nothing mentioned like that. So this one is a asymptomatic. Matching with our question with primary, yes. Do you find antibody test positive? This is the most important part in this question. Did you see any antibody positive? No. Right. So no antibody test, and also the panel test like ENA is also negative. So my dear doctors, your final diagnosis here is it is a primary Raynaud's. Primary Raynaud's. So this will be the question given. Some cases primary, some cases secondary. With the secondary Raynaud's, everything will be changed 35 years with SLE-like features with autoantibody positive. Then your answer would be high chances SLE. We have seen two type of question from there. One is the primary in past and one with the SLE one. Please mention in the comment section if you are clear with the Raynaud's phenomenon. I want you this one to take a picture actually. Yes. Yes. Understandable, guys? Is it looking too difficult at this point? Some concepts can be new, but it depends on how we are reading this and how you are memorizing this. It's very important you have a study partner. Whatever I teach in the classes, you quickly discuss, then you go to the next step by question bank, by recall solving, by this, that. But first, yeah, that's the thing. Okay, not clear. Not clear. Which part not clear? Okay. This is the question. First of all, Raynaud's phenomenon in exposure to cold, color changes in the skin. Coming to the next part, this is that question. As you can see, 25-year, you have to remember the parameter. So 25 less than 30 years, then the symptoms, like there was no SLE symptoms, so it is asymptomatic. You see the antibody test, it is also negative. So in primary, it is also negative. Panel test, negative. Okay. So which box it is now clear? It is towards the primary. I hope it's clear now, dear doctor. I hope it is. Yes. It's just a math type. It's just a math type. I hope that's clear now. We're almost heading towards the end. Scleroderma we done. Proximal muscle we done. Raynaud's we almost done. Okay. Last but not the least, polyarteritis nodosa. We're almost at the end, guys. Polyarteritis nodosa, it's a vasculitis type, but as I said, vasculitis type is mostly we'll read in the renal. Yes. Okay. Can you tell a few important points? Multi-system disease? Yes. Vasculitis type of disease? Yes. One finding I want to look forward. Multi-system is that hepatitis B often positive. Hepatitis B often positive. Very important. In first 2 or 4 classes, usually we recommend just follow classes and finish the class things first. Then gradually you speed up. Now, John Murtad, I feel didn't written much things properly. for polyarteritis nodosa. Okay, this is how sometimes in the exam they might give you a scenario like a 43-year man with hepatitis C or hepatitis B complains of chest pain. While leaning back on examination, there is vascular markings like this. So this can be a scenario with the polyarteritis nodosa. So scenario based would be given, multi-system things would be given. Or many times as a diagnosis, they will tell you this is polyarteritis nodosa, or they'll give you a scenario and they will ask you what test you need to do next. This is how MC often asks questions. What is the next test? What is the accurate test? Now, this is the MC important part for polyarteritis nodosa. Initial test, ESR reactive protein, inflammatory marker. Accurate test is a biopsy. Accurate test is a biopsy, very important for us. Which biopsy? Mostly renal biopsy, but there's another special biopsy available, sural nerve biopsy. I'm sure you know about sural nerve in between the legs, the gastrocnemius muscles. Clear, everyone? Special line other than arthritis, multisystem involvement, hepatitis is a special term. So treatment of polyarteritis nodosa, because multisystem, so eventually prednisolone and cyclophosphamide, and treat the cause like hepatitis B if it is found. Okay. If the note is also given in the SMA note section, you can also check. My dear doctors, is it clear about the time polyarteritis nodosa? I believe so. Yes. All right. It's a more, I would say, nice to know topic instead of like rheumatoid arthritis. Some of the big arthritis keep coming. So these are more like a innocent, nice to know topic. Now, this brings us to the point, a very hot topic now, before at the end. I'll tell you the scenario. A person who is 50 years presents to you telling you about severe headache, which is like a, temporal type of headache. One sided, like this is temporal headache. And they also complain that I have problem in my vision. All right. So what do you think what it could be? And if you do a test, ESR could be positive as well. So without any further delay, you have to give a high dose of steroid because your diagnosis is giant cell arteritis. And in giant cell arteritis or temporal arteritis, same thing, your treatment without any delay, high dose of steroid, otherwise loss of vision. High dose is steroid in order to prevent loss of vision. Yes. Is it clear, everyone? So clinical scenarios are here, over 50. Some cases jaw pain as well, temporal headache as well. Yeah. Confirmatory, there's a thing given, but often we don't do it, is a temporal artery biopsy. Often we make the diagnosis clinically, and you have to act very quickly. Act very, very quickly in this case. Okay. Dear doctors, today's last topic is Behçet. It's another one of the rheumatological condition which is more common in male. We just remember Behçet syndrome with a mnemonic as well. Mostly we remember Behçet with a mnemonic. With that mnemonic, we'll be finishing today. The mnemonic is RUST. RUST for Behçet. Okay. This is like something recurrent oral ulcer, then uveitis, I, then but for the S, anything, skin changes, erythema. Okay, last but not the least, it is a test, pathology test, positive pathologic test. So mnemonic is RUST. Okay, mnemonic is Rust. So more common, few lines. More common, it's in case of male, 2:1, but it can also happen in female. Often can be related to STD exposure, and this for spatial finding and arthritic features, of course. Okay, so that goes with the Behçet. You need a high dose of steroid for Behçet, 213 page, and disease modifying anti-rheumatoid drugs. Okay, I hope the Wegeners will read with the respiratory. Yes. Positive pathologic test, my dear. It's done in the skin, actually. That's the only thing you need to know, actually. Someday you do more higher post graduation, then you need to know how to perform the test, method of the test. That time you need it. For now, positive pathologic test, actually. In the skin, it is done easily. It's more like the tuberculin test. Yes. Okay, so that's, I think, all from that rheumatology. I think everyone is tired. One thing I'm doing, yeah, I'm going to show that one how to access through the drive. And before that, I'm opening an inquiry zone. Of course, I'll upload the lecture one by one, guys. Please hold on. I'll opening an inquiry zone. First of all, I'm opening an inquiry zone. I know everyone is tired, where you can ask me anything. Okay. So you go to the batch, this one, if you can see batch 69. And in this one, I just opened a inquiry zone. You can ask me anything first of all. Now, last but not the least, I'm just going to show you how to access through the SMA notes. That's one of the thing before leaving. And some of the strategies. The classes are normally upload overview. This is a normally upload the overview about the page numbers, like the pages of John Muktak. If you want to study in advance, so definitely you can go through it. Okay. Then Sunday we take the theory class, and Thursday we take the recall class, and then we take the mock test. About the mock test, with the time we'll tell you. Actually, every week there will be a mock test. On the top, you need to have John Muktak 9th edition and class things you need to study along with classes. And using this SMA note, this is how the SMA note looks like. I think 90% of the doctors we have sent it. Those already received the SMA note can comment in the comment section. I mean, if you have joined. Some people have this view of the notes, but I think it's better to use the this layout view. Now, if you go to the aim for medicine, yes. Yeah, mock test in the week. We'll talk about mock test later. I mean, I'll give you idea on the next class on mock test. Okay, is that fair? Yes. Okay, so you go to the medicine and the rheumatology, M for medicine, M for rheumatology. Yeah, so now you see the M for, yeah, so rheumatology, giant cell arteritis, drug-induced myopathy, then gout, rheumatoid arthritis, yeah, SLE, vasculitis. So you see the relevant topic, all these things are given actually. Okay, so you follow them. These are like quite genuine notes, very to the specific notes actually. All right. Uh, about buying books, John Murtak 9th edition is the only book you need to have hard copy actually. About the remaining thing, about soft copies will be provided. I think that's the thing. All right. Yeah, these notes you can study and this and that. Yeah, that's the thing actually. You cannot download them. Yes, of course. Yes. All right. So, anyways, guys, it's quite a long session. Again, I would highly recommend you guys can go to our uh, I'm sharing some resources link that would be more important for you guys. Yes. So please check out our, if you want to check the course details, you can WhatsApp me. You can also send me direct message in the Facebook Messenger. You can join our guideline group. So this all important, relevant information today we took. Also, which is the related AMC websites. I give you the link. We also we have mentioned about our guideline group. Yes, so that'll be helpful for all of you. And there's inquiries on my post. Please leave message because we all are tired. So I'll take some time and then check your messages. You can also drop me message in my inbox, and class related anything you can also ask there. Uh, Joining is straightforward. You can inbox us. We'll send you some informations or we'll ask you a few informations. If everything fits, then you can also make payments and then you can join the course. This whole month, the admission will proceed. You need to give your Gmail, and in that case, we'll send you the materials. In that case, actually, in that through the Facebook Messenger, actually. Yes. All right. So thank you, my dear. Thank you. And especially Dr. Munira, thank you. I mean, you attended last batch as well. And I wish you all the best. And same time class on the Thursday, guys. Same time. I'll see you guys same time, but that would be rheumatology questions solved. All questions of rheumatology will crash it together. Okay. See you on Thursday. Good night. I'll keep it open for a few seconds. Thank you, all of you. And a few links, these links, please check all these links, guys. Try to check all these links. Yes, just try to check out these links. Some official websites, some our discussion groups, some related to our pages. And yes, all the best to all of you. If anyone is a medical student, please check the YouTube channels for now. In future, come to us for guidance, or you can leave a message. We can also get it. Yes, yeah. Though, I mean, if you do not receive message, I mean, notes yet, leave us a message. I think in next 24 hours will be definitely how to get ninth edition. You need to buy it actually, or will be provided soft copy later. No worries on that one. Yes, but all of you need to study because we are marking things actually. Yes, we are marking it. In the course, we share it ninth edition, so don't worry on that one. Yes. Thank you. And try to use laptop next time when you come to the classes, guys. Try to use horizontal screen rather than mobile screen because classes are long, so your eyes will have a lot of trouble. Okay. So I don't know his name, Samsung Mister. Okay. All right. So see you in the next class. Good night. Wish you all the best. I'll keep it open for a few seconds. Yes. Thank you.